Your Excellencies, dear distinguished guests, ladies and gentlemen, it's my great honor and privilege to welcome you to the One Health Summit partner event, financing the One Health agenda. So we will talk about public development banks in action. I'm Isabelle Grommet. I'm the founder and CEO of Goodness & Co. and your master of ceremony for this morning event. We are here because we cannot have healthy lives on a sick planet. We know that One Health is the missing link between the health of people, health of animals, and health of our planet. And we know very well that we continue today to treat these challenges as separated. But we cannot longer afford a fragmented approach. This is not anymore an option. Why? Because we rise or fall together. And the cost of inaction has become higher than the cost of action. So today, One Health is no longer a concept. We are here because we believe it's a strategic imperative. And more than ever, public development banks are playing a pivotal role. So the question today is not anymore about why should we finance the One Health agenda, but how. So today, we will together, during our panel and keynotes, articulate the case for investing into One Health, identify how public development banks can scale, because the question of scale is on everyone's lips. We will clarify also operational pathways to promote transparency and scalability. I feel deeply grateful for your participation, for your commitment today, for joining us. Please, let me remind ourselves that we are in this exclusive session. We are held under the Chatham House rules. Thank you. So it's my great honor, and please join me in welcoming Grégory Doucet, our re-elected mayor of Lyon, and the co-founder of the One Health for Cities network, which gather 25 cities in 2022, and we look forward to hear from Grégory Doucet. Thank you so much.
Mesdames et messieurs, vous ne m'en voulez pas ici, depuis Lyon, de parler en français. J'ai croisé la ministre de la francophonie hier, donc voilà. Je me dois de me plier à certaines règles. Mesdames et messieurs, en vos grades et qualités, d'abord, et aussi en tant que maire, permettez-moi de vous accueillir, si je n'ai pas déjà eu l'occasion de le faire, et de vous souhaiter la bienvenue ici à Lyon. Vous imaginez, pour le maire que je suis, la joie et la fierté que cela représente d'accueillir un sommet international sur le One Health, qui est la boussole de nos politiques publiques depuis maintenant près de 6 années, que j'ai eu la chance d'être à la tête de cette magnifique ville de Lyon. One Health, c'est ce qui nous a permis d'améliorer, par cette approche, ce qui nous a permis d'améliorer la qualité de l'air, l'alimentation dans nos cantines. Je ne vais pas égrener ici tous les exemples qui illustrent la pertinence de cette approche. Depuis maintenant 2 jours, eh bien, nous parlons One Health partout dans Lyon, et j'espère que vous avez eu l'occasion, au travers des séances auxquelles vous avez assisté, d'être convaincu de la pertinence de cette approche. Vous dire que, en tant que maire, nous avons, avec mon exécutif, mes exécutifs, fait en sorte que One Health irrigue l'ensemble de nos politiques publiques. Pourquoi ici à Lyon l'avons-nous fait? Parce que, tout simplement, la santé au sens de la définition de l'OMS, un état complet de bien-être physique, mental et social, et pas simplement une absence de maladie ou d'infirmité, eh bien c'est tout simplement l'objectif que nous nous sommes fixés quand on est un élu local. Le bien-être des habitantes et des habitants, c'est essentiel. Mais si c'est vrai ici à Lyon, c'est bien sûr vrai aussi sur toute la planète. Et pourquoi est-ce que les villes sont-elles la bonne échelle pour mettre en œuvre cette approche One Health? Tout simplement parce que nous avons dans les villes, entre les mains, quand nous sommes à la tête de ces villes, eh bien, l'essentiel des services du quotidien à la population, que ce soit l'aménagement de l'espace public, que ce soit l'éducation, que ce soit l'accès à des équipements sportifs. Eh bien, tout cela constitue autant de leviers pour pouvoir agir sur le quotidien des populations. Et cette approche One Health, eh bien, nous permet d'irriguer dans toutes les politiques cet objectif de santé et de bien-être. Mais si nous pouvons le faire à l'échelle de nos villes, aujourd'hui, nous avons besoin d'aller plus loin. Seuls, isolés sur nos territoires, bien sûr, nous pouvons faire progresser cette approche, mais nous nous sommes rendus compte à plusieurs, vous citiez cette alliance des 25 villes, en réalité, nous sommes d'ores et déjà bien plus nombreux à vouloir développer cette approche One Health. Nous avons, mesdames et messieurs, besoin de vous. Et c'est dans cet esprit que nous avons créé la One Health Cities Alliance, une alliance de villes qui veulent aller plus loin sur l'approche One Health. Aller plus loin, concrètement, ça veut dire quoi? Ça veut dire mettre en place, bien sûr, des projets qui contribuent à cette approche One Health, mais nous avons besoin aussi, en tant qu'élu local, de pouvoir nous rencontrer, de pouvoir échanger, de pouvoir constituer une alliance qui nous permettrait aussi d'aligner nos politiques publiques avec les grandes initiatives internationales menées par à la fois les organisations internationales, mais aussi portées par nos gouvernements. Et c'est pour ça que, pour mettre en place cette alliance des villes pour l'approche One Health, nous avons besoin de vous. Quelques minutes auparavant de cette session, j'échangeais avec nos amis de l'Agence Française de Développement pour leur faire part de notre projet de monter cette alliance. Et j'espère que nous pourrons compter aussi sur vous, mesdames et messieurs, pour aller plus loin. Et donc, nous comptons sur vous, nous, les villes, pour pouvoir constituer cette alliance et la faire vivre dans les prochaines années. Merci à vous et encore une fois, bienvenue à Lyon.
Thank you so much to our mayor. And now I am very pleased and honored to welcome Laurent Bidiscombe, the Executive Director of Sustainable Development Solutions at the French Development Agency, member of the Executive Committee, a key figure in development finance, working at the intersection of public policy, finance, and sustainability, and former Deputy CEO of Socredo Bank. Thank you.
Merci, merci Isabelle. Thank you, everyone. I'm going to switch to English to ensure all our friends who made the trip here to Lyon are able to understand more or less what I'm going to say. So the mayor left us, but thank you very much to the mayor of Lyon and his team for welcoming us here in Lyon. It's an honor for us to be able to organize this event with all of you in this wonderful city, and we're very happy to organize these events. Mr. Minister, Mr. President, Excellencies, ladies and gentlemen, thank you all. Let me please thank you all for being here today. We're very happy at AFD, in partnership with the Finance in Common system, to organize this event. Let me tell you that we're not gathered here for a mere technical symposium. We're here to address a clear challenge, working together to provide solutions that fully account for the interconnection of human, animal, plant, and environmental health. Indeed, the interdependencies of these different healths are intensifying under the effects of dynamics we know all too well: climate change, the degradation of ecosystem, urbanization, pressure on biodiversity, and the intensification of global trade. These challenges and the crises associated with them will not be resolved in silos, nor in isolation, but through cooperation, innovation, and the mobilization of all stakeholders, both public and private. As public development banks, we have a special role to play by placing the One Health approach at the heart of our strategies. That's the choice we made at AFD. We've developed our project portfolio much more assertively since the COVID-19 crisis, and we've also taken strong steps to integrate climate resilience approach in everything we do. So since 2016, we've decided that everything we do finance at AFD is compliant with the Paris Agreement on climate. It's been last year about 7.7 billion euros that we committed to climate resilient operations, and within our health approach, about 70% of what we do is climate proof. So it's an essential part of what we do. In concrete terms, it means strengthening pandemic preparedness and response, supporting agroecological transitions, developing more energy efficient and resilient hospitals. We did that in Réunion Island in French overseas territories. We did this in Rwanda also. And it means also strengthening adaptive social protection in the face of climate shocks. So in short, it's about durably anchoring a planetary health approach that strengthens national systems, mobilizes public and private investments, and supports global public goods in an increasingly fragmented world. This requires coordinated actions on an international scale, consistent with the principle of the Pact for Prosperity, Planet and the People, as well as the mobilization of the entire financial system. And this is precisely where we have a major role to play as development banks. For what gives us our strengths is also our capacity to act collectively. As you know, within the Finance in Common network, which brings together 530 public development banks, and particularly through the Coalition of Public Agriculture Banks and the Coalition for Social Investment, we are helping to ensure health is recognized as an essential lever for adaptation to climate change and to structure common approaches. Thanks to the diversity of our instruments and the volume of our financing, we have a decisive role to play in scaling up. This is what's at stake in our discussion today. And under the auspices of the Finance in Common system, they must lead to a clear call to strengthen investments in favor of the One Health approach and to structure a common framework to ensure monitoring and accountability. These commitments will translate into a joint declaration intended to be one of the structuring deliverables of this summit with a G7 endorsement. So I hope that our discussion today will nourish and strengthen this collective ambition. And thank you very much for being here. Thank you.
Thank you so much to our distinguished speakers for setting the scene. Before we move into the first panel, let me remind everyone in this room that you have headsets for a translation that are available for you. If you need any, there is a team that will be able to help you. We need one here. 2, 3, please raise your hands. So you see here a few headsets are needed. Please raise your hand again, sorry, just to make sure that the team here is able to see you. Okay, thank you so much. So now we're gonna move into our first panel, which is about why financing is critical today. And to guide us into this conversation, it is my honor to welcome on stage Agnès Souka, a leading voice when it comes to financing the One Health agenda, Director of Health and Social Protection at the French Development Agency, former Director at WHO, and Chief Economist at the World Bank, who will chair our first panel. Thank you.
Thank you very much. Good morning to all, and thank you so much for your presence this morning. There are today more than 450 public development banks in the world, and they mobilize about $2.3 trillion every year. This is 10% of global investments. These banks finance both public and private investments in all sectors of the economy, including infrastructure and human development, including a variety of short-term and long-term financial instruments. As such, they are uniquely placed in the world today to invest in comprehensive multi-sectoral programs such as One Health that require investments in sectors as diverse as health services, agriculture, water, education, social protection, or environmental services. Investing in One Health solution is needed to respond to both environmental and social challenges as part of a planetary health vision. The implementation of these solutions in full alignment with the principle of the Prosperity Pact for People and the Planet, the 4 Ps, we're going to hear about it today. It calls for a multilateral and coordinated approach grounded in the mobilization of all stakeholders within the global financial system. So what is the potential role of these development banks in financing the One Health agenda? To address this question, we're really honored today to have a formidable panel of speakers that are going to illuminate us in sharing their thoughts about how to transform the global architecture for better financing those programs that are going to protect us, that protect the global community from the threats that are there, from the environmental degradation and challenges that the world is facing today. To respond to this question, let me call first Honorable Minister Mohamed Pate, Minister of Health and Social Welfare of the Federal Republic of Nigeria. He's a medical doctor specialized in infectious disease, and he's a leading figure in global health, and was formerly the Global Director for Health, Nutrition and Population of the World Bank Group. Dr. Pate, please join the scene. Next in our welcome is His Excellency Moussa Fakir, Special Envoy for the Pact for Prosperity, People and the Planet, to speak about financing One Health in a changing world, from Seville to Accra and Lyon. His Excellency served as Prime Minister of Chad between 2003 and 2005 and completed 2 terms as Chairman of the Africa Union Commission, spearheading initiatives such as the Africa Continental Free Trade Area and leading strategies on health and nutrition, development financing, environmental action, and peace negotiation. Please welcome. Let me welcome Dr. Sanya Nishtar, CEO of Gavi, the Vaccine Alliance. Dr. Nishtar will previously serve as Health Minister in the government of Pakistan and previously co-chaired the WHO High-Level Commission on Non-Communicable Disease. She brings extensive experience from the highest echelons of international governance. Her career is defined by her unwavering commitment to health equity and governance reform, and she will speak about the new financial architecture for global health and the partnership that she has spearheaded between Gavi and public development banks. Let me now welcome His Excellency Dr. Jean Kaseya, Director General of the Africa CDC, where he leads the continental strategic response to health emergency and the strengthening of national public health systems, partly spearheading the new public health order. Let me welcome next Mr. Akihito Nishio, Vice President of Development Finance at the World Bank, where he oversees the World Bank's strategy for resource mobilization, especially for the International Development Association and the International Bank for Reconstruction, and spearheading the reform of the global financial architecture to better address climate change, poverty, and sovereign debt challenges. We will be joined shortly by Mrs. Priya Basu. She's still held in another panel, who is the executive head of the Pandemic Fund, and she oversees the first multilateral financing mechanism dedicated to helping low and middle income countries strengthen their preparedness for future pandemics through a One Health approach. And last but not least, we will have a voice of science to speak to this issue, and we're happy to welcome Professor Serge Morand, a distinguished ecologist and evolutionary biologist. He's a member of the One Health high-level expert panel. He's advising the WHO, WHH, FAO, and UNEP. His expertise focuses on the impact of environmental changes and biodiversity loss on the emergence of infectious disease. His numerous seminal work has played a pivotal role in developing global strategies that integrate ecosystem protection into public health. Please, Serge, join. So let's start, and to no avail, I will ask Honorable Minister Mohamed Pate to share his vision.
Well, thank you. I think, as you've laid out, COVID-19 was a crucial moment for the global community in terms of infectious disease risks, how we address them, how interconnected our world is, how health is linked to economics and overall development. The fact that we've not been invested enough or have not invested sufficiently enough before COVID in various aspects. But even before COVID, we know that there were several issues that were lingering since the early 2000s, 2009, 2012, 2014, Ebola, Zika, and all of those issues that led on to COVID-19. And the multiple interdependencies, I think, became very clear, and the fact that we were unprepared. But coming out of COVID, what do we learn about that? I think we're still recovering from the shocks of COVID. I would say a lot of what we're seeing, even 6 years down the road, is somehow the aftershocks from the impact of COVID, politically, socially, economically, institutions, supply chains, and all of those. In the context of Nigeria, we reflected on those lessons. And we developed a structured reform process in our federal system that was adapted to our local context, that laid out the issues of governance, of health systems, the basic elements of delivery, which we have to put in place, the value chain, the manufacturing, but also health security, including the cross-sectoral issue, cross-cutting issues of digital transformation, how we organize financing, how we build our national institutions. And the key elements of our approach essentially started with the idea that, in fact, nation states, countries have to take responsibility, set their agendas, and have to build the whole of government, whole of society consensus. In the federal system, the federal government, states, local governments, but also interconnected with others in the region, in Africa, but also globally. Not in isolation, but to take responsibility, to step up, prioritize and mobilize our domestic financing, including complementary development financing from other institutions. Taking a sector-wide approach so that within government, Ministry of Health, Ministry of Agriculture, Livestock, Environment, Water come together. We have a very robust One Health platform, which I chair, comprising all the ministers in those areas, so that we are coordinated in the way we approach these issues, not only in terms of One Health or pandemic preparedness, but broadly in terms of the determinants of health outcomes for our population. Thirdly, expanding the issues of social protection that is linked to health, whether it's insurance, whether it's other mechanisms to ensure that the community engagement and the citizens are also carried along, and strengthening our health insurance authority, focusing on the vulnerable population, because the truth is that if there's a crisis, you need everyone to be on board. If we allow those on the margins of society to be out there, when there's need for their cooperation, we'll struggle to have that cooperation. So expanding and attending to the vulnerable groups is key. And finally, the value chain, which is a key lesson that we've learned from the pandemic, that the countermeasures platforms, diagnostic kits, pharmaceuticals, vaccines over time, and other innovative tools, clinical research, to localize them. It's a long journey. It's not going to be easy, but to put in place mechanisms to be on that path, even if it's 5 years, 10 years, but at least to be able to domesticate that. And to do that in cognizance of other countries in our region that are also similarly moving in that same direction, so that we're not cannibalizing each other. Now, in terms of the financing agenda, I think there are a few shifts that become very evident that we have to address. One is from short-term emergency responses, what the World Bank, I think Priya and others were saying, the cycles of panic and neglect, which is recurrent. We've had at least 5 of those cycles in the last 25 years. To begin to think of longer-term prevention and resilience and investing towards that. The development banks, I think, have a crucial role in that because their financing is more long-term than others. I think the second one is from siloed to more integrated One Health investments. In Nigeria, we've got large IDA support, which I think AFD is joining in that, and others are also joining. So it is a platform that is bringing various actors, including on regional health security, and from fragmented in-country aid to aligned but country-owned financing compacts, so that all actors have sets of expectations, asks and offers, and accountability measures that we take stock together. And from purely public funding to smartly blended finance that also safeguard the public interest and equity. So the private sector, we also try to mobilize that, especially when it comes to localization of manufacturing. And finally, from flows that were not very transparent to more transparent, more accountable. And our platform for the sector-wide in Nigeria has been able to give us visibility, and including some of the major bilaterals that have come back to the table. So it's a much more visibility in terms of what everyone is doing, reducing dependencies, multiplications, redundancies, and ensuring that the most important priorities are attended. So I think those are some of the shifts that we can take on as we continue to improve on the ability of the world to be more resilient for the next challenge, which is not if, but when. But we have to do it together. So thank you.
Thank you very much. Thank you, Honorable Minister. Thanks for your leadership on the profound rethinking of the global health landscape. Your Excellency, Moussa Fakir.
Merci, Madame. Moi, je ferai comme le maire de Lyon, je vais parler en français. Et je voudrais d'abord le remercier de nous accueillir dans cette très belle ville, Lyon, qui est connue pour sa gastronomie, pour ses fêtes des Lumières, mais c'est également un haut lieu de la santé. Mesdames, Messieurs, un constat a été fait. C'est celui qui consiste à reconnaître que le financement du développement, dans sa version originale, a montré ses limites, pour ne pas dire qu'il a vécu. C'est la raison pour laquelle, en juin 2023, s'est tenue une réunion à Paris sur le pacte financier mondial, sous l'égide du président Macron, et nous nous sommes entendus accorder sur l'impérieuse nécessité de réformer le système financier mondial en vue de son adaptation aux objectifs et aux défis du présent. C'est la raison pour laquelle a été mise en place une initiative appelée 4P, le pacte pour la prospérité des peuples et la planète. Ce pacte, cette initiative, travaille sur les questions de la dette, sur les questions de l'environnement, sur la question de la mobilisation des financements innovants. Aujourd'hui, l'un des problèmes les plus cruciaux concerne la santé. J'ai passé les 8 dernières années en tant que président de la Commission de l'Union africaine et nous avons porté au fonds baptismaux Africa CDC, dont je salue la présence du directeur ici, le docteur Kassea. L'Afrique a également lancé l'Agence africaine des médicaments. Mais il faut reconnaître que la question du financement se pose et va se poser davantage avec acuité. Donc il faut réfléchir sur d'autres voies pour pouvoir mobiliser en tenant compte, en tirant les leçons du passé, d'abord en se basant sur les besoins réels des pays eux-mêmes, leur approche, l'effort domestique pour mobiliser ce qui peut être mobilisé et attendre le soutien de la communauté internationale, et notamment les banques de développement pour pouvoir imaginer un nouveau système qui puisse soulager un tant soit peu des pays comme les États africains qui sont en très grande difficulté. 2 ans après, l'été dernier à Séville, nous étions arrivés à ce qu'on appelle le compromis de Séville, qui consiste à réaligner les flux financiers avec le développement durable, l'action climatique et la résilience. Récemment, en Afrique, au Ghana, a été lancée une initiative, Accra Reset, également se basant sur une approche nationale et régionale, mobiliser les acteurs africains eux-mêmes pour pouvoir faire face à la très impérieuse et épineuse question de la mobilisation des ressources pour le financement de la santé. Alors, les banques de développement ont un rôle particulièrement important à jouer, de par la nature même de leur rôle, leur envergure, leur connaissance du terrain, puissent imaginer d'autres formules pour pouvoir soutenir les États, notamment les États africains, sur la question du financement de la santé. Pour cela, il nous faut nécessairement nous réorganiser autrement. Il y a une multitude d'acteurs dans le secteur. Il y a parfois même des chevauchements entre les actions des uns et des autres. Il y a une nécessité de coordonner l'action pour avoir une dynamique commune en travaillant ensemble. Je crois qu'on ne dispersera pas les moyens et peut-être qu'on arrivera à une masse critique qui puisse permettre réellement de soulager le secteur de la santé, notamment dans le continent africain. Alors, Lyon est un rendez-vous important. J'espère que des engagements seront pris et qu'une coordination puisse voir le jour et que l'on puisse parler de manière très concrète, j'insiste, de manière très concrète, sur des mécanismes qui puissent nous permettre d'avancer sur ces terrains. Voilà, Madame, très brièvement, l'approche qui est celle du 4P, et nous sommes disposés à travailler avec tous les acteurs, notamment les États, les institutions internationales, les banques de développement qui ont un rôle important pour qu'ensemble, nous puissions constituer un système qui puisse, de manière très originale et de manière très pragmatique, apporter des solutions à un secteur qui en souffre beaucoup. Merci.
Merci beaucoup. Merci beaucoup, Votre Excellence Moussa Faki, pour partager avec nous cette nouvelle vision du développement à la croisée de l'agenda environnemental et de l'agenda du développement humain. Et c'est là le grand défi d'aujourd'hui. Let me now let Dr. Sanya Nishta share her vision as the head of the Global Vaccine Alliance.
Thank you very much, and thank you, Agnes, and thank you for your leadership in organizing this event. Good morning to all of you. It's a pleasure to be here. Congratulations to the government of France on this seminal event. Your question about financing the new architecture is very important because, of course, we are all talking about a new global health architecture. But there has to be a conversation about how the financing plumbing of that is going to be put in place. And sometimes how you fund an initiative actually determines its shape. So it's a little bit of a chicken and egg situation. So once again, thank you for putting this question on the table. I think we really need to unpack it a little bit because there are so many aspects of the reform of the global health architecture, so many directions in which we need to go. We need to be clear about what financing instruments and approaches we're talking about. And I'd like to classify them in 3 categories broadly. The first category belongs at a country level. And I think there are some things we're talking about and there are others which we should talk about more. For instance, there is a broad-based agreement that national sovereignty and national self-reliance should be at the heart of the conversations of the global health reform. I couldn't agree more with that. An important corollary of that is the reliance more on concessional lending and the newer approaches that you talked about, NES, in your opening statements, tapping into public development banks, tapping into that 2.3 trillion that remains untapped. We currently don't have the tools, the instruments, the approaches to do that. And that level of understanding about what can finance at the country level, that level of understanding is sinking in. But there are other things that we should talk about as well with reference to financing of the country development landscape. One of them is devolution of decision-making to countries. I think it's absolutely critical. And as part of our own reform at Gavi called the Gavi Leap, that is the first step we took. It is so important to devolve decision-making to countries. That is an important accompaniment of the national sovereignty movement that we all agree on. The other aspect of financing is the disbursement and the utilization of that financing at a country level. And I think we need to pay more attention to that as well, because currently there's huge fragmentation. If you walk into any partially aid-dependent country, you will see at an average more than 10 UN entities operating there. You will see large funds such as Gavi, the Global Fund. You will see philanthropies of all shades and colors. You will see bilaterals operating. You will see multilaterals operating. You will see development banks. And there's huge fragmentation. Each one of us, and Mohammed will agree with me, when I was in the cabinet, the largest department that I ran was the department that had to interact with all the development agencies. Each one of them has a different grant cycle, each one of them with different reporting indicators, audit requirements, accounting treatment, standalone procurement systems, standalone guidelines. Each one of them have different teams. Each one of them has a different governance arrangement, and that really needs to be fixed. We shouldn't just talk about the global health architecture. We also need to talk about the local health architecture. This is what ministers deal with on a day-to-day basis. So at a country level, there are different strands of the financing conversation, starting from the sovereignty side, starting from how countries should improve the tax to GDP ratios, to the transition from grants to the concessional lending and the untapped resources, to the devolution of decision-making, and the merger of financing at the last mile. And that's one bucket of things that need to be fixed. The second bucket of things that needs to be fixed is the financing of global public goods at the global and regional level. One of the constant mistakes that we make is to conflate financing of the global public goods with development assistance, and we bucket it under ODA. We need to unpack it, because global public goods in health are the things that matter to every country of the world. And I strongly believe that these should be financed by all countries of the world, ideally through a first charge principle, legislatively mandated in budgets. And there should be a very lean structure and AI-enabled institutions in today's day and age to execute on these. And we need to radically rethink about how we shape these institutions. For instance, what relevance is there of having a 3-tiered technical assistance post-Second World War apparatus in this day and age, where the same function can be performed by an AI bot for 1/100th of the cost? So I think that's the second bucket of financing conversations, and stemming from that, the architectural conversations that we should have. And thirdly, we should think very clearly about development assistance, because institutions such as the earlier product development partnerships and the post-2000 Gavi and the Global Fund have played an enormously important role in saving lives. And what element of these institutions are we going to preserve a decade down the line as we talk about transitions, as we talk about devolution of responsibilities to regions and countries? And I think that's an important conversation that needs to be had. And clearly we need to preserve funding for fragile contexts. We need to preserve funding for humanitarian settings. We need to preserve funding as an equity lever. And I think the third bucket is the bucket that relates to new ways of thinking, because we're talking about reform of the global health architecture. Are we talking about redrawing things on a blank page? And if we are talking about redrawing things on a blank page, then we must think of a few things that we haven't thought of before. For instance, are we going to use this opportunity to truly restructure for One Health? And if that is the case, there are huge opportunities. And are we truly going to talk about sharing of responsibilities between global entities and regional entities and ultimately transition? And I believe there's a huge opportunity to do that. And are we really interested in the game-changing innovations that the technology of today offers? And again, there are huge opportunities. So in the end, I'd like to say that at Gavi, we are really embracing this opportunity to create an institution for the future. For instance, as we speak, our Gavi Leap reform is further along to devolve responsibility and decision-making responsibilities and authority to countries where it belongs. We are having meaningful conversations and are forging meaningful partnerships with regional entities, and Jean is here, to ensure that we share responsibilities with them and we transition responsibilities over a period of time. We are actually listening to people on the ground with reference to sovereignty movements, and we're taking decisions based on what we hear. And today I'm going to be making announcements based on how we've restructured one of our instruments called the African Vaccine Manufacturing Accelerator based on what we've heard. We're also making an announcement about the Gavi resilience mechanism, because we know that in a world of shrinking ODA, funding for fragility needs to be protected. And of course, we are making the merger at the last mile within our ecosystem an actual reality, because this is what I heard within the first 10 days of coming into this organization, and Mohammed will bear me out. So I think change is possible. And in all humility, I'd like to say that we as an organization are trying to create a Gavi for the future, for the future global health architecture. And in humility, I'd like to say that the Gavi Leap reform basically demonstrates that reform is possible. If you're willing to be bold, if you're willing to cascade your intent into implementation. And I fundamentally believe that it is quite feasible to do it at a larger scale at the global level as well. The world is changing. It's the time for countries and regions, and the sooner we appreciate it, the sooner we make changes, the better it would be.
Thank you very, very much, Dr. Nishtar. So along with a bold reform of the financial architecture, you as the leader of Gavi, you show that it is actually not only feasible but desirable to really go for a bold reform of the global health architecture. And Gavi in so many ways leads the way, first with your vision, but also with actual measures, as you said, responding to the new technological environment as well as the new geopolitical environment, including the demand for sovereignty of countries. And that makes the transition with the next speaker, Honorable Jean Casseya. Cher Dr Casseya, je vous laisse la parole pour nous dire comment le CDC Afrique voit cette réforme que vous conduisez au niveau du continent, en particulier avec the new public health order and the new financing era. How do you see unfolding in the next few months and years?
Thank you so much, Agnès. I would love to speak in French because, you know, I'm proud to be Francophone, but I will not do that. Because I'm told that we don't have so many headphones. And I don't want also some of my friends I see here to say, Jean, why you are not helping us to get your message. But you know, Agnès, you did a great job. I can see Moussa Faki. You know, when I joined Africa CDC, he received me in his office. He said, please help us not to have another pandemic. And when we have outbreaks, make sure that it won't spread everywhere. I think maybe he forgot, but it was the first message he gave me. And I'm so glad that we worked together for almost 2 years and a half. We did a great job. Thank you, Moussa, for being here. And also all good friends, Pate, Sanya, and all of them. I see Priya coming. You know, colleagues, when we are negotiating the pandemic agreement, a message came to me. They say Africa doesn't like One Health. I said, but this is a lie. It's a lie because in Africa from 2012 to 2022, we saw an increase of almost 63% of zoonotic diseases. It means mostly our outbreaks, and if you consider that every year we have around 200 outbreaks, almost 1 outbreak per day if you exclude weekend and public holidays. Okay? It means for the past 2-3 years, it was 70% of our outbreaks mostly being zoonotic. Then if there is a continent pushing for One Health, it's mostly Africa, more than Europe and others. This is the first message. But when we talk about One Health, what was the issue? How are we financing this One Health? This is the discussion that we had. And today you will see Minister Pate made it. Many African leaders, when they start to talk about financing of the health area, they don't start to talk about what partners are giving us. We start to talk about what are we mobilizing internally. I think you saw my op-ed with President John Mahama, and you saw also my op-ed with President Tshisekedi a few weeks ago. A country like DRC, known for being almost a country requesting money from external partners, they took time for 1 year to work internally to find a way to get innovative financing and to move from almost 9% to 14.5% of national budget for health coming from the national treasury. Yes, we are not talking about 14.5% of the US budget. We are talking 40.5% of the DRC budget, but at least it's a progress that the countries are making in Africa. Minister Pate, I attended your meeting last year. It was last year or this year, I start to forget. But the annual review meeting, even I committed that this year I will bring a number of ministers in Nigeria because we see progress. But Nigeria, DRC are not the only countries. We have Rwanda, Ghana, and so other countries. Our job in Africa CDC today is to map all of them, to start to talk about our success in Africa. Yes, we have success in Africa, but we are not talking a lot about it. This is why I think some of you saw yesterday, I appointed Professor Yemi Osibanjo, who was Vice President of Nigeria. A brilliant person, one of the sons of Africa that all of us we love. We said, please come to help us to structure the strategic thinking. And today, I think you saw, is joined by a number of other people. Pierre Delso, who was leading ERA. Christopher Ben, who was a co-founder of Global Fund, a man known for the debt swap, because we need to unlock debt swap as innovative financing mechanism. Troy Fitrel was leading the Africa Bureau at State Department. And Benedict Orama was leading Afrexim Bank. Why all of these big fishes decide to join Africa CDC? Because they know that we are making change in our continent. We are making things moving in Africa. We believe on that. We want you to believe on that. Because the agenda of financing One Health today in Africa, it's mostly the agenda of sovereignty. We cannot talk about sovereignty if you think that your money must come from another person, another continent. You must first generate your own resources. Today, I was in conversation with President Mahama, and we are meeting for a high-level meeting with President Macron. We'll discuss again that. We are clear on the way to move forward in Africa. Then, when we talk about getting more money, the second one comes. How are we using this money? Let me try to convince you. The main problem in Africa is not just lack of resources, it's wastage of resources. One example, DRC, they signed $900 million for 5 years with the US, while they are wasting every year $800 million with ghost workers. I don't know if someone get my message. It means if they don't waste $800 million per year, in 5 years, they have $4 billion, while they are signing $900 million with the US. Am I saying that we don't need US money? No. But I'm saying we need to use properly our money. Ghost workers, fraud in procurement process. We have a number of other areas where we need to fix. I know in African country I will not name 32 strategic plans not speaking to each other. 11 digital platforms. Even the minister is telling me, DG, why I cannot go back to the manual process? Let us lead our countries. We don't want to be led by partners. We want a minister to sit and to say, this is my plan. One Health means one plan. This is the Lusaka agenda we are talking about. One plan, one budget, one implementation model. If we have one plan, yesterday I was talking with my good friend, Minister Khaled of Egypt, an African minister. I said, do you know that in Africa we have countries with so many plans? He said, no, DG, it's a joke. In Egypt, I have one plan. An African minister who doesn't believe that a country can have so many plans driven by partners. This is the third lesson. I said the first one, more money. The second one, how to use our money. The third one is how to align partners to make sure that we are following this one plan that the government is giving us. Then, we are talking about GaviLip. You know, Sanya knows that. Sanya, why you are not giving me the title of GaviLip champion? We are supporting GaviLip because we see how a global health mechanism is aligned under the vision of the government. But we have also pandemic fund. I think, Priya, you will talk about how we are leveraging resources. And I have some numbers here. For money that pandemic fund invested, we have leverages around 1 to 7. You know, this is the proportion of money that we leverage from other sectors and private sector. And we see the impact at country level. Yeah, I was also talking with colleagues from Green Climate Fund. I will stop there. Because,
you,
you know,
Dr. Kassé.
I'm so passionate with that.
Yes.
But let me stop there and saying something critical. My main message is, when we talk about One Health, those who are thinking that the bilateral agreement will be the solution, it's a mistake. We cannot do that without a regional approach. And today, we are also saying, if there is an outbreak in a country signing a bilateral agreement, it doesn't mean that this country cannot be affected by what will come from non-bilateral agreement. This regional approach is important. But I think you need to create 15 minutes for me.
We need to create a new time path. Thank you so much. Thanks for your passion. Thanks for your leadership. Let's move quickly to Priya Basu, who is the Executive Director of the Pandemic Fund. Please, Priya. I mean, Dr. Kassé made the transition by talking about how important the Pandemic Fund is in this financial transition. And please share your thoughts about how we are on that path.
Thank you very much, and great to be here. So, you know, I think the One Health high-level expert panel, thanks to the work of that panel, we share now a common understanding of the One Health approach, and this approach is gaining momentum. But I think, you know, implementation still remains challenging. Some government sectors are more engaged than others, and some countries lack the necessary resources. And so this is where really the Pandemic Fund comes in as a funding mechanism that places One Health at its center. We offer countries incentives to adopt One Health strategies, enabling them to build capacities in a more collaborative manner. And right from the beginning, we've put One Health as a key sort of underlying theme, and we're sort of saying that, you know, please use these limited grant resources to bring your own co-investments, you know, from the countries themselves, from their domestic resources. We're saying, you know, we're working with international organizations, our implementing entities, you know, asking them to bring their co-financing, but saying that, you know, a durable model for pandemic prevention, preparedness, and response really has to galvanize participation at the national or regional level across health, finance, agriculture, environment, animal husbandry, livestock, and at the global level across institutions that bring expertise in human health, animal health, and the environment. And so, you know, that is our model. And as Dr. Kassé was mentioning, we've managed to mobilize $7 for every dollar of grant funding that we've awarded. So far, we've awarded $1.4 billion, and through that, we've managed to catalyze $10 billion. About $6 billion of that $10 billion has come from our international partners, particularly MDBs, and especially the World Bank, IDA. And about $4 billion from the domestic resources of countries themselves, and so that's how we've managed to achieve this leverage ratio. I just want to emphasize that you know, investing in animal health, human health, and the environment with a cooperative approach really is the only way to ensure that we are ready to quickly detect, contain, and you know, manage and recover from outbreaks. And multilateral banks and public development banks have a central role to play in embedding these investments in One Health across their portfolios, from health, agriculture, environment, food systems, and so on. The Pandemic Fund is a concrete example of what that looks like in practice. Our model is built on partnerships, on country ownership, on mobilizing domestic investment, as I mentioned, and catalytic leverage, primarily from MDBs. But I'm happy to say also, Agnès, since you're moderating, that AFD has also come in as a co-financier in some of our projects, including a recent one in Laos. We have co-financing from other bilateral agencies like GIZ, for example, in Cameroon. And this is how you know, the fund turns a targeted grant into a platform for long-term systemic change. And we recognize that our board recognizes it's necessary really to actively work to deepen engagement with MDBs and public development banks. And we just launched our fourth call for proposals literally earlier this week, which is targeted to countries with the highest needs, highest risks, most vulnerable. 15 countries identified, with mostly in Africa, that will require targeted support over a one-year period. And so we look forward to, working with these countries and really helping them to build durable systems. Very importantly, institutions. We're helping strengthen national public health institutes and also regional organizations so that our investments are embedded in kind of long-term capacity building and transitioning to the path towards sovereignty. And maybe one last point that is very important. In order to sort of get to the sustainability, it's important to ensure that the money, the grant money, goes to governments on budget. And so that's kind of a very central feature of the pandemic fund right from the beginning. No parallel systems, no parallel structures, one budget, and aligning all the international partners that we're bringing together, aligning them around the national action plans for health security of these countries. And so we've already achieved some good results. We have over 12,000 health facilities have been strengthened for surveillance, more than 140,000 health workers, not just doctors, nurses, field epidemiologists, but veterinarians, animal health workers, park rangers, and over 300 laboratories strengthened, integrating veterinary laboratories with human laboratories. And so these are some of the early results, and we're looking forward to working with all the partners here to deepen our engagement and really to address the challenge of pandemic prevention, preparedness, and response. Thank you.
Thank you, Priya. And let me move to our last speaker from the development banks. Last but not least, the final word from the World Bank and Mr. Nisho on how the World Bank is taking this agenda forward.
Merci Agnès, c'est vraiment un grand plaisir de parler en français, ça me donne beaucoup de plaisir. Mais je vais garder ça pour ce soir quand je explore la culture gastronomique de Lyon. Alors je vais changer en anglais. So I just wanted to say, I don't think I have that much time, but I'll just say that we are, I think, at a very important crossroads when there are so many risks stemming from health that may translate into broader risks on security and other things. And at that time, at this very time, we have the ODA for the health sector declining sharply. And also, this comes on top of some very worrisome trends in aid architecture, where the average size of projects is getting smaller and smaller. And also, the number of development finance agencies is getting much higher than it was 20 years ago. Ethiopia deals with 250 development financing agencies. And that is ridiculous, but that's the reality. And also, only about 40% of ODA goes to the recipient governments. Dr. Pate talked about the country ownership, the country's centrality, but it's very difficult to exert that when only 40% of ODA goes to the recipient government. So these are the kind of challenges that we are faced with. But I think it's not all bad news. We have some solutions for this, and we at the World Bank are using those. One, of course, and probably the most important one is IDA. And France is the 5th largest donor to IDA. And IDA is present in just about all the sectors, including health. With IDA, you can leverage resources. So $1 from a donor country goes out as $4 to the recipient country. So at a time when ODA is declining, it is a very efficient way of supporting poor countries. And then we also embrace very much the One Health approach. We have, since 2021, supported 34 projects worth $4 billion. One of those projects is the Redice project that Dr. Kaseya has been working on as Africa CDC, which covers 16 countries in Central and Western Africa, building alarm systems and so forth. I think the regional approach is going to be quite important because the pathogens travel across boundaries. Now, I think there's a lot more that we can do with partners. And I'm very encouraged by what my colleagues have said about this. And Priya also just talked about how the pandemic fund is working with MDBs, including the bank, IDA. We also have a very robust partnership starting with Global Fund and Gavi, and we really want to nurture those. And I think there are some very innovative mechanisms that are emerging from countries, including the one in Nigeria called the HOPE operation. So these ways of collaboration, I think, can be further developed and replicated. Let me just say that just a couple of other things. Besides the what I just mentioned so far, there's a couple of instruments that I want to mention. One is what we call the GROW window, Global and Regional Opportunities window under IDA 21, which is available to support projects that are regional in nature or even global in nature. This is the first time we are doing something like this. And that makes available $13 billion over the next 3 years. Another one is what we call Framework for Financial Incentives, which also supports projects that transcend country boundaries. This is for IBRD countries, so this is not for the poorest countries, but the first time we are doing that for such countries. And then we are now working on what we call Day Zero financing to prepare for an onset of another pandemic by procuring medicines, etc., early. So I'd like to conclude with 3 points. First, that pandemic preparedness is impossible without resilient health systems. You have to be on the ground, you have to work with the client countries and really work together. Second, One Health demands a unified architecture and coordination, not a siloed approach, and several colleagues just mentioned that. And finally, I think we really have a window of opportunity now that we are learning from COVID, and before the next pandemic hits, I think we really need to get our heads together, work together, and prepare. Thank you very much.
Thank you. Thank you very much. Thank you very much, Mr. Nisho. Thanks, and really for sharing with us how powerful the coalition of public development banks is, and how the range of their instruments, how large the range of the instruments is. And thank you. And you see, we are losing our panelists because it's a presidential summit, so yes, there are lots that we're trying to do in one day. And we were very lucky to have this very strong panel, panel of global leaders who are moving the cursor. Honorable Minister, if you wish to go also, please feel free. But you are welcome to stay, because this is going to be, and I know how fond of science you are. You are a scientist yourself. You're an academic yourself with an appointment at Harvard School of Public Health. So now it's the time for being enlightened by the voice of science. Serge.
Thank you very much. So First, I would like really to thank everybody, and thanks especially the panelists. Thank you, Agnès, for organizing this. I want to say that first, to thanks also the France and Germany, actually, because this was in 2020 at the Peace Forum that OLEP was really created, which was a joint initiative, and we will discuss a little bit about this. But this was important because it was also the way to go for the tripartite, One Health, to the quadripartite. So put the One Health into, and the environment into the One Health. And I would like to thank very much AFD, because at the very first time there was also the launch of the PRESOD initiative, and especially the PRESOD in actions in the Global South. And I'm very happy to be also one of the co-PI from Thailand and Laos, and Dr. Sawapak was there also to present this. So the problem, I will say two problems that why the environment is important. First, because when you look at the data, and I can show you a little bit quicker the data regarding the number of outbreaks we discussed, yes, increasing for humans, zoonotic and vector-borne disease everywhere, but also increasing very much in terms of the outbreaks in the livestock and poultry sectors, which are facing every country, but also increasing very, very much also into the wildlife. Much more you see about avian influenza, for example, especially in the Americas. So for the second slide, what we can say also, this is another important aspect of this is the loss of biodiversity. And we have that in the second slide, but it's not a problem. We increase the biodiversity loss everywhere, but especially in the Global South, in a very high level. So why we have to do? So we have to go really to join on to the One Health. Alors, the One Health, we have the definition of the One Health, and thanks for the OLEP to have done that. But the One Health, we can really see that is really the 4 C's. Collaboration between sectors and disciplines. Sometimes even in disciplines, we are more a lot in silos. Collaboration, coordination with the civil societies at all levels. Rural for urban. All of this to really implement capacity to implement really the One Health for healthy ecosystem as a support for healthy humans and healthy animals. And finally, what is very important is communication. But communication is also advocacy. And advocacy is why we are there. It's also for the financing. But this is the problem for the moment. For the One Health, I have to say, that we are really critical point because still the environmental sectors is not enough there, even into the disciplines. So we need to get them more inside. And the way that was very important is to use also the planetary health. Because if the One Health approach is very good in terms of action, in terms to integrate people to go on, we need a vision. And the vision is given by the planetary health, which is more transformative, and we have a real good vision within the planetary boundary. And I will finish because thanks with this again for AFD, because what we are really doing in ASAMCO, one of the part of the PRESOD action in the Global South, is prevention at the source. Prevention at the ecosystem level, prevention at the interface between domestic animals, wildlife, humans, and the environment. And we hope to get some very good news. So more stop to see about dramatic increase of biodiversity loss on this, but really to make action and innovation really on the field and to favor the science policy dialogue. Thank you.
Thank you very much. And this is where I would actually like to conclude this panel, that when we talk about financing One Health, we're not only talking about transforming the financial architecture, we are talking about changing the framework of investments in health. That is the change in paradigm. And if we see that over the past 25 years, we really made a lot of progress on access to technology, access to medicine, access to vaccines, we have now reached another phase, another era, in which we need to align our financing capacity globally to respond to the challenges of today, which are at the challenges, the environmental challenges, we were all made aware during the pandemic of COVID-19. It's about a new framework of investment. So it's not only about investing more and bringing all the partners at the table, all the financing institutions, those 450 and plus financial institutions to fund this agenda, but it's also about financing a new agenda, investing differently. Thank you very much. Honorable Minister, thank you so much for your leadership on this agenda. We feel so honored you were here. Thank you. Again, as you see, we are operating in a summit that has a very tight program. So we've taken there is a bit of delay now. So we're going to move to the next panel, and very importantly, the next panel, as much as the first one was looking at the role of public development banks and why they should be funding this agenda, the second one is really going to look at the how, and start actually with the question of how do we invest in science and data, and how do we move forward on getting the world more ready to anticipate and respond to pandemics. So I'm now calling our distinguished keynote speaker for the next session, and I'm asking the Director General of ERA, Dr. Florica Fink, to come to the stage. So as so we will have two keynote speakers for our second panel, as we now turn to this core question of how public development banks can concretely deliver through strategy, instruments, and partnerships, and scale up One Health investments in a constrained global financing context. So, Dr. Florica Fink, you are the Director General of HERA at the European Commission. You are heading Europe's work on medical countermeasures, from early threat detection to development, procurement, and deployment. And we are now also introducing the second keynote speaker. We're very honored to have with us Professor Victor Nzo, who we are truly honored to have with us today. He's the president of the US National Academy of Medicine and the co-chair of the G20 high-level independent panel, where he has been instrumental in shaping a new global financing agenda for pandemic preparedness and response, reminding us that the cost of inaction is far greater than the cost of prevention. So let me give you the floor first, dear Dr. Fink-Huger, and share with us the experience of HERA, which is an institution that was created out of the experience of the COVID pandemic.
Je vais commencer d'abord quand même par remercier la France et le président Macron d'avoir organisé cet événement, parce qu'en fait, cette vision et surtout cette reconnaissance politique de dire que seule une planète saine peut aussi garantir notre santé, et avec notre santé aussi cette stabilité économique et sociale est très importante, et surtout à ce moment-là. Cette idée de lier les deux, la planète, la saine et la santé. Et because planetary health and human health are really two sides of one coin. And I will explain to you a little bit like how we work as HERA with public banks. But I would also want to say that when you listen to the first panel, which was an excellent panel, you also understood that clearly when we look at the financial architecture, there is an overburdening. ODA is shrinking. We all look at the same mechanisms, blended finance, going for philanthropies, and it's often the same. And as Sanya Nisha also was saying, it's all a lot at the same time, and you should perhaps make some coherence about that. But I think when you look as an example for pollution would definitely, if you were to curb pollution, you definitely act on health, but you also would act on, will act on climate change and on biodiversity or loss or environmental degradation. So it's a non-brainer to say, where do I can combine or maximize my funding by going on multiple benefits. So that is not so much saying that you can all put in one pot. It's not possible, because on climate change, biodiversity, it's often mitigation, and health is clearly adaptation. But still, the principle of maximizing financing that is shrinking would make sense. And I would also like to say that it's not just about breaking silos, can also be connecting silos, but you look at what brings multiple benefits, and I think that's perhaps already part of the solution. DG HERA is looking at what we call medical countermeasures. So these are vaccines, therapeutics, but also protective devices or detection devices. And these are often niche products, and for that money is even more scarce, because there is no return on investment. It's not commercially always viable. So that is a challenge, but you can still overcome that. And of course, HERA has on its own quite a lot of money, but we need to leverage that money, because otherwise we will not overcome the difficulties, because for medical countermeasures, the research and development is extremely, extremely costly. And as I said, there's not necessarily an immediate commercial value or commercial return. And also we have that famous valley of death to overcome. Therefore, it makes sense to go and work with public banks, because they can leverage that financing that we have, and that we have been entrusted with by our taxpayers, because we have as a mandate to provide the citizen or the taxpayer with medical countermeasures in order to be prepared for a health emergency. But even though you say, oh, these are niches and niche products, they actually also have a transformative character, because if we invest in these MCMs, we also strengthen the supply chains, which in current times is also quite important. Or we would help operationalizing then into having it in stockpiles or in other types of purchasing agreement. I would like to give you 3 examples how we concretely work with public banks, so as to show how you can connect the different planetary health, but also health challenges together. And the first one is obviously with France, with the Agence Française de Développement, and we work on dengue. I mean, dengue clearly is a climate-driven threat. It is coming up very much also in Europe. It links to climate change, but also to environmental degradation, biodiversity loss. There's still no treatment available, and while it is not necessarily high, mortality is clearly having a morbidity impact, and therefore also an impact on economic performance. So one should take that very serious. But it does have systemic challenges. Very high research and development cost, low commercial returns, although I think if we would have a breakthrough, because dengue is everywhere in the world, I'm quite sure you would have a good commercial return, but for the moment people don't see it like this, and you have very limited private investment. So what we are doing now is we are investing with the French Development Agency 20 million for 4 years into a project that would be then implemented via the Drugs for Neglected Disease Initiative, the DNDI, where we go for 2 advanced clinical trials, because clinical trials is always the most critical part of the research and development part, and then we would go for also securing, hopefully promising antiviral compounds that could then go through partnerships, industrial partners. We have very strong industrial partnerships into production. And we would also like to step up a global clinical trial networks for dengue via the Dengue Alliance. So this is just a part on where we invest in dengue. We also go for many other targeted investments on our own, but with Agence, with the French AFD, we really want to step up this clinical and antiviral development. Another one is with the German KfW, that is the Kreditanstalt für Wiederaufbau, another public bank, and this is on antimicrobial resistance. I mean, we all know that this is a silent killer. Even routine operations could turn badly because you don't know whether or not individually you would still have the resistance towards this antimicrobial resistance. So here we go into an financing of 30 million euros together with the German Kreditanstalt Wiederaufbau, and we have again, of course, knowledgeable partners, implementing partners is CARP-X and CARP-DP, and there we go really for a sustainable pipeline. We go for early stage and late stage research, and that is very important because that's otherwise where you go into this valley of death, and it's really wanting to accelerate the whole pipeline approach. And the last one is with the EIB, on which I'm very proud because we have created a specific facility which we call Hera Invest, dotted with 100 million, which we are now scaling up to 200 million. But the bank is scaling up that and leveraging that much more because ultimately we have quasi venture capital investments. And that is super important because we really do look, and this time we look more at European industries, but we look at small scale startups or SMEs to look at where can they help us in producing an MCM, which is in a niche, and then leverage that up. We look together at projects. The bank gives us the assurance that it is financially viable, but we also look from a scientific point of view together with them. So that's quite a unique way of working and very promising, and we would like to scale that up even much more, so does the bank. So just to conclude, there are possibilities to combine, be it investment in health or into climate change and environmental induced infectious diseases. It's quite possible. And honestly, it is not so much the political will that will save us in a crisis. It's actually funding. Honestly, we need funding. And this is not cheap. Development, research and development is cost. But the cost of inaction will be so much higher. And we have seen that with COVID. We have all experiences all over the world. And some countries are still struggling with the fallout. So I think going and finding good financing mechanisms is important because then you address also multiple challenges, planetary challenges, but also human health. And I think as we heard in the first panel, there are possibilities to blend it, to combine it, but we have to break the silos or at least connect the silos and go for those that brings the maximum of benefit. I would stop here. Thank you.
Thank you. Thank you. Thank you very much, Mrs. Fink-Hoyer. Thank you. I think this is really, as I said, HERA is very much an institution that emerged from the COVID-19 pandemic. It's very new and it has already done a lot. And part of what it has done is foster the financial partnership, as you said. Yes, there is a need for more financing of public goods or global commons. And what HERA is doing is a global public good, a global common. There is a need for more money, but that money can be raised through these innovative approaches of blended financing. It is about getting that firepower of public development banks, and you are already doing it, and doing it for transformative projects that are, and I remember Dr. Nishtar in the first panel saying we need to distinguish the development argument from the global public good argument. And here, we're really talking about mutual benefits. It's not about the North helping the South. Actually, the dengue project is about the South helping the North, because Thailand and Brazil and Malaysia, they know much more about dengue than we do in Europe. And this is a truly global mutual benefits project. And I think this is so important to say that we are already walking the talk as a global community in that new framing of global health as a global, as a mutually benefit global investment. But Dr. Nzo is going to say much more about that, because this is what the high-level, the G20 high-level panel is all about. This is the second report, which was just published, and is even more fascinating than the first one. The first one led to the creation of the pandemic fund, which we heard just before, the success of the pandemic fund in leveraging the funding of development banks, $7 for $1 in the pandemic fund, $7 of investments in One Health and pandemic preparedness. But what is next? So Dr. Nzo, we want to hear all about your recommendations about how we move to the next step.
Well, thank you very much. Agnes, thank you and AFD for organizing this, and Remy Roux for really leading this effort. It's been a great journey working along with you. And you talk about the how. I would say that much what I'm going to talk about have a degree of specificity, but it resonates with the first panel. It's about global domestic resource mobilization, about mobilizing development banks, and of course, having partnership with HERA and many others. So I would say first to say that what a pleasure it is to be actually presenting along with DG Feng Hosier, because HERA is doing so much work supporting many of the initiatives that we're trying to work on. So when she mentioned about the dengue lines, reminds me of a conversation you and I having about the Therapeutic Development Coalition, in which IPPS, I'm a co-chair of the science expert group, is launching with Unitate hosting this, moving forward with the idea of creating antivirals against all the potential pathogens that can give disease X. So thank you very much indeed. What I'm going to talk about is the G20 high-level panel. I have a series of slides, but I'll go through fairly quickly because of time. First of all, back then in 2021, during COVID-19, we were asked by Italian presidency of G20 to convene a high-level independent panel to say, what do we need to do for the issues of pandemic preparedness, response, and prevention as well. And of course, what happened is we set forth a series of actionable items that we presented, in fact, to the finance minister and central bank on July 2021. Next slide. And really what happened is the important findings of this, as you already heard, is one, it is global public good. So consequently, we want to say that everybody has worked collectively together to increase financing PPR. And our number was $75 billion over 5 years, with more to come. And you heard today that if everybody is rowing the same direction, we should be spending at least $15 billion a year for global public good. But we also suggested the idea of a global health threats fund of $10 billion a year. Now that, in fact, is what they gave birth to the pandemic fund. And in fact, during the G20 Indonesia presidency, it was launched, the pandemic fund. You heard Priya talking about, even though we only got $3 billion, was a 7.3 to 1 ratio and leveraging tremendous amount of dollars that's doing a lot of good. Third, we said there should be, in fact, a global health threats board, which really led to the Italian presidency at the end of the presidency to establish the Joint Finance Health Ministers Task Force. So all that led to a series of good actions. Next slide. But of course, we know it's not enough. And of course, now in the more recent changes in geopolitical situation, disruption in global architecture, we're asked to reconvene the group again by now the South African presidency to come together to say what we need to do. Well, this slide just simply tells you about the important issues, which is the massive cut in high-income countries of ODA. And pandemic risks are really increasing because we know that the outbreaks are occurring more frequently and even more severe. So it's not going away. As many people say, pandemic, well, it's not if, it's really when. So consequently, we decided that we should reconvene this. But I want to point out that the recommendation here complements the pandemic agreement as well as IHR reform, etc. We meant to support all these changes. Next slide. So first of all, we reconvened the group. And you can see I have a very excellent co-chairs with Jean Kaseya, Jane Houghton, Bengt Orama, and John and A. Rottingen. Now, we brought back 50% original panel and 50% of new ones. You can see Ngozi and others, Crystallize, are all brought back to help work on this. We had two working groups, one on surge financing and the other on preparedness financing. Next slide. Okay, so what do we find? We find there are really 5 major gaps. One is that there's insufficient, of course, investment and financing for pandemic PPR. And particularly with the ODA declining, there's a need for a lot more for domestic financing and non-ODA support. You already heard that discussed in the first panel. Second, there's insufficient financing mechanism for access to MCM and surge manufacturing, particularly during health emergencies. Third is there's clear lack of clarity and incentive for at-risk financing from the developing banks, the World Bank, the public development banks during health emergencies. I'll come back to this later. Fourth, of course, we all know that PPE tests and treatments are all underfunded and under-prioritized. And finally, you heard the pandemic fund. Even though we're off to a great start, it's still under-capitalized, and we need to find ways to support this. So that leads to our recommendations. Next slide. Next. So you can see there are 5 major recommendations that really addresses the gaps. And I'd say again, when I think about the first panel, in many ways, the how is all in here, particularly focused on pandemic PPR. First, of course, is unlock domestic resource mobilization, mobilize non-ODA spending, and this is a very important issue. Second is accelerate geographically diversified regional access to MCM. Third is to look at development banks at-risk financing, particularly during purchasing at a time of emergencies. Fourth is, in fact, on operationalizing financing for tests, treatment, and PPE. And finally, strengthen the pandemic fund, cement it as the world's most premier preparedness financing facility. So I'm going to go through each one of these very quickly, mainly focus on the slides recommendation so you can move on rest of the meeting. Next slide. On the first one, it's very clear that we say all governments should be committed to domestic mobilization. The idea that we say all governments should have a costed plan to look at what are the kind of dollars needed in order to, in fact, provide this kind of health budgets. And in this regard, we think about several sources. As you can see on the right-hand side of the slide, we say every country should have benchmarks. And the benchmark that we put forward is against, in fact, the GDP, as well as against some potential of resources from defense budget. So we ask government to invest a minimum benchmark allocation upon 1 to 0.2% of annual GDP towards pandemic PPR. Second, given the fact that many high-income countries are increasing their defense and security budget, and this is health security to be sure, we said we should at least 0.5% of security defense budget to support PPR. So, you know, when you think about this, it's really hard for us to know how much countries are spending and how do we know that countries are actually mobilizing those funds. So our proposal is to create a tracker, a pandemic spending tracker, so that by the time we come to the UN high-level meeting in September for PPR, we're going to have, in fact, an announcement of such a tracker. In fact, we're working with HERA, with the OECD and World Bank to create such a tracker. Next slide. The second recommendation really looks at how to accelerate geographically diversified and regional access to MCM, particularly during outbreaks and also pandemic threats. And there we need blended financing for regional manufacturing. Now, regional manufacturing, as you know, is gaining a lot of momentum, but we want to be able to say there's enough financing for this. So we're calling on the International Finance Corporation, IFC, along with other finance institutions to establish, in fact, a dedicated MCM surge financing facility for working capital. So that's so important, and we want this to move on very quickly. In addition, we need a standby roster of regional manufacturers that can actually build on pooled procurement mechanisms. So the other recommendation we have is, in fact, on risk financing. Well, during COVID-19, it was very clear that countries were unable to secure concessional loans to procure MCMs more quickly. Why? Because the condition is that the MCM products should be pre-approved or pre-qualified by WHO. And of course, if you think about how quickly you need to move and how you need these products, you have to be willing to take a risk financing for those products which are not quite ready, but in fact have some approval processes. So what we want to do is to work with the World Bank and public donor banks to enable pre-negotiated, rapid, effective at-risk financing for advanced purchases of MCM, particularly for low and middle income countries. And in this regard, you can see down in our point is that those, in fact, who already have received a level of WHO country, what they called, let me make sure I get it right, level 3 maturity or higher, that we can actually give them provisional and approval and the temporary approval so that they can procure this at risk. So this is a very big issue that we've been speaking to World Bank and others, and that we're now getting tremendous positive reception that's likely to move forward with this altogether. Next slide. Finally, the recommendation 4 and 5. In 4, we are looking at treatments, PPE, and tests, and we want to say that we should designate a specific anchor institution or institutions that would develop scale test treatment and PPE and launch a financing strategy to deliver this mission by 2026. There should be at least one PPE manufacturing hub with stockpiles in each region. And of course, finally, importance of investment in platform technology and others. And our last recommendation is, of course, in Pandemic Fund. We want to make sure this is a premier preventive financing facility, and therefore we're asking the bank and other investors to give a rolling model proposals to give support, and the pandemic fund being able to require matching funds from other countries, other partners. Next slide. So that's where we are. We have lots of recommendations, and this year we're spending in implementing them. You can see the slide, lots of activities, lots of discussion. We are meeting with the major leaders along and moving along with many of these recommendations. As you can see, we're going to have at the spring meeting at the World Bank a side meeting on this issue, and also in the G7 Development Ministerial meeting, a discussion on the PPL investments. And finally, we are planning other workshops to keep moving on this issue. My final slide, please. We had really enthusiastic support from Jean Casteller, from President von der Leyen and others to say this is really ambitious but needed. So I would argue the time is now. And this quote that I have here to say, pandemic prevention stands at a precipice, but moment of great change can unveil unexpected opportunities. We're still living in an age of pandemics. However, humanity has the intelligence and resources necessary to turn future pandemic threats into preventable, treatable diseases. We simply need to mobilize them. Thank you very much.
Thank you very much, Dr. Nzo. Thank you, Mrs. Fink. I think you both really outlined the new framing for global health financing. And these are, the recommendations of the high-level independent panel take it to a next level as compared to the first report that led to the global the pandemic fund, this global facility that leverages the financing of public development banks. This is now happening, right? And the question is now, and you said the question is implementation. It is happening. You have very concrete recommendations on how to mobilize capital, how to mobilize private financing, how to mobilize domestic financing, how to get the public development banks to back up domestic financing through their different final instrument. This is a vision, and France is really happy through its G7 event this year to really support these recommendations and move forward with this. And we hope to move as a Team Europe as a Team Europe at implementing this program, and certainly we as a financing institution are very much behind this agenda. Thank you very much. Thanks for your thoughts. And we're actually going to continue this topic by calling a panel that's going to talk to us on how we're going to implement these recommendations, what are the next steps. And it is my pleasure to call the panelist of the panel that is going to comment on this first two keynote speeches. First, let me call Cécile Billot, who is the head of health for the European Commission, INTPA. Thanks, Cécile. We're delighted to have you with us today. The EU has developed a powerful set of instruments, blending, guarantees, and concessional financing to support investments at scale. Diane Menville from IFAD, Associate Vice President and Chief Financial Officer at IFAD. Thank you for being here. Idrissa Dia, our dear colleague from the Islamic Development Bank. Idrissa Dia is director at the Islamic Development Bank with over 30 years of experience in infrastructure and development finance. And Islamic Development Bank is our dear colleague, member of the Finance in Common Coalition. And it's my pleasure also to welcome Mr. Stavros Nicolaou, the Group Senior Executive at Aspen Pharmacare, a leading pharmaceutical company with a strong footprint in Africa and a key player in local manufacturing of vaccines and essential medicines. And development banks are extremely pleased to have you here, Stavros. It's a real pleasure to have you with us today. Aspen is a dear partner of us. He's been working closely with development finance institutions, including IFC, Proparco here from the French side, DEG and DFC, to scale up local manufacturing capacities in Africa, a critical dimension of health security. You're really a main actor of the health sovereignty of agenda of Africa that was spearheaded by the Africa CDC, the Africa Union. Let me also welcome Maha Keramane, the head of the Positive Impact and Inclusion Accelerator at BNP Paribas. So here is about the mobilization of commercial banking, private banking. We know COVID-19 has really shed light on the weaknesses of health system and how they affect the economy. We all remember 4% decline in global GDP. This has really brought health in the mind of commercial banks, and she's going to tell us all about it. And finally, Benoît Faraco, who is our ambassador of France for climate negotiations, decarbonized energy and climate risk prevention, and here with us to share with us how now health is a major agenda within the environmental and climate agenda. Thank you very much. So let me really start with you, Cécile. Can you share with us how partnerships with public development banks have helped you align and optimize your full range of instruments from blending to guarantees, and how the Commission is actually operationalizing One Health through its Team Europe approach?
Thank you, Agnès, and good morning, everybody, and thank you. So I will keep it very focused, and also we had Florica just before who talked about what DG ERA is doing. I'm coming from another part of the Commission, but working very closely with colleagues from DG ERA. But of course, our focus is international partnerships, so it's broader than only MCM, and it's really directed with partnership with Africa, but also Latin America and some Asian country. What you said also, Agnès, just before, you mentioned a word which is very important, or two words, Team Europe. So when we are working together on One Health, on health in general, we are really trying to pull forces from all EU member states in a Team Europe format, and to pull together projects, to pull together our resources to have more impact in certain area. So when we look at health, we have, together with a couple of member states, many member states, put One Health as an important area of our Team Europe work. So we have a Team Europe sort of platform on One Health. France is a big partner. We also have Belgium, Germany, Sweden, Denmark, and I probably forgot some of our member states which are really committed together, and we are doing a partner project also that are both kind of more ambitious kind of project, working with public development bank, but also some technical assistance, working with our African partner, and really trying to help also on the capacity building, which is still very, very important. Now, to come back to our topic on what kind of tool do we have, and trying with this graph you will see on the slide to be educational, or at least to be clear about what we are doing. So we still, as a Commission, do sovereign loans, and this is really with our public sovereign counterparts, so with the countries. We are not a bank at the European Commission, so of course we work with public development banks like AFD, also with EIB, to really put this sovereign loan into place to assist the government in health and in other areas. And that's still something which is important. What we bring there as a country is, of course, as a Commission, is, of course, the sort of guaranteeing the risk or taking the sovereign risk aspects for it and working with EIB and others. And we bring also a part of grant also into that sometime. It depends on each of the projects. So that's the classical way of working, which has been working a lot, and we still are doing that with our many partner country. But we also have other tools, like we referred, and that was the conclusion also of the HLAP report, blending. So we are doing more and more blending mechanism and also guarantee. Blending mechanism, so mixed of grants and loan. We are really working with our public development bank, but development bank, DFI, EIB together, and really to provide also the blending mechanism to the private sector. So really coming in with a part of grant and then giving the loan there. And that's really mechanisms that we want more and more to be used, because we all know that ODA is limited, and that to trigger and to get this leverage aspect, we really need to get private actor on board. So this is an integral part of what we do, and an increasing one that we are doing. And of course, we have the third mechanism of guarantee, and then the guarantee is really, we don't put as such any money into it, but we guarantee we take the risk, and often the higher risk. So banks feel more comfortable basically to go and invest in our partner country, which is often very risky partner country, where the banks are not always the most ambitious, because they are banks at the end of the day, even they are development banks. So they don't go to this country which are more difficult, and we really try with these tools to take the full risk, so in case it doesn't happen, we will pay that back, and try really to be more ambitious and to support with a guarantee. So a guarantee it's new in a way. I mean, we have been doing it like for 5 years and more. It takes some time to get to work, but it's already, and in the health, it's already being implemented and delivering some results. And that's what I wanted also to showcase to you, and that will be, I think, the next slide, because it's very relevant to what we're doing. It's one of the guarantee which we call Human Development Accelerator. Some of you may have heard about it, HDX. So it's a product basically, and each product we do it a bit differently, so we have different way of putting together, but this product is really done with EIB, the European Investment Bank, together with the Gates Foundation, who come also with matching grants, meaning they put also one part of grant into the project, so we have more grant together to blend in project. And we have 3 different tools available. We have a more classical kind of corporate loan, which we have to say it's not the easiest to deploy, because there's not so much interest into it. So this is a part of the mechanism for the time being where there's less interest. But we have what is very in demand is, of course, a venture debt, meaning that, okay, you do a loan, but basically the company do not have to pay until 10, 15 years. So it's very interesting, especially for vaccines and for long-term projects. So this is very much in demand, and this is a product which it doesn't exist enough on the market, so we see a lot of attraction, lots of projects. We have announced already a couple of projects actually under this one with BioNTech in Rwanda, for example, to build the manufacturing capacity, and we have many other projects that is coming up and that will be announced also this year, including also at the spring meeting. And we have third volume guarantee, which is, yes, I will cut, volume guarantee, which is really about guaranteeing a certain number of volume in terms of buying. So that's the size of it is pretty big. It's 1 billion. It's going to be deployed now in the next 2 years, and this is something which we think it's a good way of really providing something that doesn't exist enough on the market, and which we've been really working also with, for example, Proparco, because we come with one part of the investment, but then the idea is to gather other public banks, development, DFI, to come in and take the other part of the investment, which is lower risk, where they are more comfortable to invest. So basically, this is also attracting a lot of capital. So this is this kind of mechanism that we are looking more and more. And I know we are short in time, but I still want to mention something, because we talked quite a lot about the pandemic fund and the role of the pandemic fund. And just to recall, as Team Europe, we are also representing 43% of the financing of pandemic funds. So that's also very important to recall, because this is an important element. Thank you.
Thank you very much. Yes, Team Europe believes in global public goods. Thank you very much, Cécile, for your actionable perspectives. Let me turn now to Diane Menville, the Associate Vice President of IFAD. IFAD is at the forefront of linking food systems, climate, and health. Can you share how investing in agroecological transitions can concretely support the One Health agenda?
Thank you very much. And I am the CFO of IFAD, so I want to thank you for bringing health experts, agricultural experts, and finance experts together, because we are all needed, especially to address a defining challenge, which is how to protect human health while safeguarding the planetary systems that make health possible. And my message is very simple. Health, food systems, and climate are inseparable. Right now, we have 700 million of people suffering from hunger, 800 million people living in extreme poverty, mostly in the rural areas. But at the same time, the climate is disrupting agricultural production. But there is even a deeper layer of risk, which is the way we produce food. The way we produce food is a primary driver of global health threats. Zoonotic diseases, antimicrobial resistance, vector-borne illnesses are amplified by ecosystem degradation and unsafe food systems. Over recent decades, the outbreaks have costed millions of lives and trillions of dollars. But for low and middle income countries, these are not just health crises. This is years of development that have been wiped out. So the question before us is not sectoral, it's not agriculture, health, it's systemic. How can we feed the world, meet climate targets, and reduce pandemic risk altogether? So for those who don't know IFAD is a UN agency, and it's also a concessional multilateral development bank specialized in agriculture. But what we do, we focus on the first mile, the smallholders farmers, the most vulnerable rural communities where health, environmental, and economic risk strongly intersect. And if health was not a standalone pillar of our strategy, our investments have always reflected a One Health approach. We believe that agroecology, regenerative agriculture are not just environmental transitions, they are vital public health interventions. So you can see some examples on the slides in our portfolio of things we do that illustrate the One Health approach. Let me give 2 examples. In Kyrgyzstan, IFAD strengthened animal health through community veterinary services. So by improving vaccine access, by training paravets, by supporting the smallholder farmers, we haven't just protected herds, we've protected the people there. And when we do that, it also comes with economic outcomes. The households who participated, so incomes rise by 40%. The production of livestock value grew by 70%. Another example would be in Brazil. The Amazon Sustainable Management Project supports rural communities in adopting forest practices and introducing integrated pest management that boost income while protecting biodiversity. So by doing so, we are managing the human-wildlife interface to reduce the risk to the next disease spillover. So these aren't just social or health projects, they are also investments strengthening rural economies. Well-designed agroecological shifts deliver economic, environmental, and health outcomes together. So now, how to scale this? To scale this, we need institutions that operate at the system level. This is why public development banks are pivotal. They provide 2/3 of formal agriculture finance worldwide. They provide a patient capital that stays in place when private markets withdraw. And also they can leverage. So this makes them privileged partners in building a One Health financial architecture. You have been describing which type of instrument, but let me be very brief. Indeed, a credible architecture requires a range of instruments, grants and concessional finance for public goods, long-term investment for scalable infrastructure, risk-sharing guarantees, risk-sharing instruments to mobilize more, to mobilize private capital, and innovative solutions like debt swaps, innovation and optimization being key when ODA is under pressure. So IFAD offers the full range of these products, but also collaborate very closely with EU, with the World Bank. But again, I think that finance enough is not alone. So what we do is we combine with technical assistance and knowledge sharing. Technical assistance is needed to make sure that finance translates into measurable impact. So this is why I would like to illustrate very briefly another beyond project, one thing that we have developed, which is the Rural Transformation Financing Framework. It's a taxonomy. The climate finance benefited from green taxonomies. Investors know how to invest. This is more complicated for rural transformation. This is where we come with our expertise. Another initiative is the Agri-PDB platform that were launched together with AFD and FIX, connecting 150 development banks and sharing knowledge. So to conclude, if One Health is about recognizing interdependence, financing it must be about building connections between sectors, institutions, and instruments. If we get this architecture right, we won't just be financing projects, but financing resilience and prevention. Thank you very much.
Thanks very much, Diane, for voicing agriculture banks and how you have these hundreds of banking institutions who invest in agriculture and can be vehicles for One Health investments. Right? This is really one more message that goes in the direction of this coalition of financing institutions. So it's not only health services, but it's also agriculture. And you already have those actors together, working together in the Agri-PDB platform. Let me now move to Idrissia Dia, Director at the Islamic Development Bank. The ISDB brings a unique perspective with your strong expertise in infrastructure, but also very strong engagement in social sectors, and health is one of your key area of investments. Could you share how you are integrating the One Health approach into your dialogue and your operations?
Thank you very much. Good morning to everybody. Merci au gouvernement français, à l'AFD et au CIRAD de nous avoir invités ici et de nous permettre d'être partie à cette importante discussion. Now, going directly to your question, I would say that I will start with an opportunity, an institutional opportunity. The department that I have the privilege to lead, by its structure, is pulling together already health, agriculture, water and sanitation, urban development, global practices. So in itself, institutionally speaking, gives us an opportunity to make those sectors work together, which has been one of the key weaknesses so far, including in multilateral development banks, where we have been working in sectors in a siloed manner. And this has been mentioned many times over the past 2 days. Now, we are not entirely new to the One Health discussion, although we are relatively new to the discussion at a global level, in the sense that our portfolio spans already across all the very foundational sectors that constitute the pillars of the One Health, and I mentioned it. We invest a lot in infrastructure related to health, agriculture, water, but not only the infrastructure only, the soft parts of it also. My colleague Jan mentioned it, and we are not so different in that sense, that we development bank bring not only the financing, but we bring also a unique ability to pool knowledge and capacity development into our package of development assistance, and this is also what we do. We are also making progress in the way where we work to integrate the different sectoral interventions into a more One Health compatible agenda. And we have been working with HERA. The DG was there just before us. And we work with Gates Foundation and other philanthropies in pulling together resources to finance part of this agenda. I give the example of the water and environmental surveillance, which is very important to you, Hera. We have been working since Bali 2024 on that, organizing events and trying to really work together as a consortium to bring in interventions that are compatible with that agenda and have allowed a big outreach. How do we make One Health work through our operations? I will give just 2 quick examples that are very practical. You were mentioning earlier the Kyrgyz Republic that you were working with IFAD. They have approached us recently for a water supply and sanitation project in a classical manner. We have worked with them to re-engineer the project in saying, we have here an opportunity to tap beyond providing clean water and sanitation services, but to enlarge the spectrum of the project and its design to embed features of environmental surveillance and using wastewater sampling to work on prevention and preparedness, anticipating the next outbreak of disease. So this is how we can move from ordinary traditionally built projects to actual interventions that embrace the One Health. The last one is that we have approved 3 months ago an ambitious Africa Resilience Livestock Program where we target a minimum of 400 to 500 million US$ in financing focused on Africa. So this is a livestock program originally designed to tackle the issue of food security, mostly. But we have embedded in its features also dimensions related to zoonotic diseases surveillance and AMR to make sure that here also we have an opportunity to make the different dimensions of the One Health work together within the classical interventions that we do. So I can stop there in the way we approach the operational part of it. Of course, on the financing part of it, like IFAD and like our colleagues of other MDBs, we are also packaging together loans that directly allow the member countries to benefit from financing to this vital sector, softer as possible. So we have concessional loans, and we just created 3-4 months ago, we launched very concessional financing window, which is called ICF, which is a kind of replica of IDA that would be geared to tackle for low-income member countries, essentially, essential financing that would go to these areas that for which the economic outcome are on a long-term perspective. We also finally work with WHO and EIB under the framework of the Health Impact Investment Platform, where we build investment cases with high level of bankability for activities and projects and programs that help anticipate the
Thank you.
Allow me just to complete here and saying that that model of platform could be something that we can replicate here. I was hearing from Professor Zhou earlier, but this model of platform, pulling together different institutions, working on investment cases to increase bankability of interventions of this case, could be replicated in the context of the One Health. Thank you.
Thank you. Thank you very much. Thanks for sharing your experience, and that's exactly what we're building. We're building this platform as part of Finance in Common, that all public development banks will together invest. Thanks for your leadership on this as the Islamic Development Bank. Let me turn now to Stavros Nicolaou. You've been working with this development bank over the past few years. So what has been this experience? I mean, what have you learned from it, and what more is needed if we are to implement the recommendation of the G20 high-level panel that you helped shape?
And yes, thanks very much. There's a lady with a board here, and I think she's saying 1 minute. I'm going to be as brief as I can possibly be. But I want to make 2 prefacing comments. And firstly, let me commend President Macron for hosting this One Health Summit, because health diplomacy trumps economic diplomacy. I need to make that point. Secondly, it's great to see, you can applaud if you wish. Secondly, if we don't have health security, you cannot grow economies. Thirdly, it's wonderful to be here with a number of stakeholder partners. And it's critical to have these conversations so we can all pull in one direction. It's even great to see my old friend Stephanie Sodo here, who's the former health ambassador of France. Now, let me address your question directly. And I'm going to get very practical. During COVID, Africa was left at the back end of the queue. We all know that. And Africa resolved that back end of the queue will never ever be repeated again. Apex to that is developing your own capacities and capabilities. It's been dubbed the African Health Security and Sovereignty Plan. Okay. So if you don't have your own local capacities and capabilities, it doesn't matter how strengthened or weak your healthcare systems are, you will simply not deal with the pandemic, and lives and livelihoods will be lost unnecessarily. The current models of financing and the partnerships with many DFRs and developmental partners, whilst much appreciated, and this is where I want to be practical now, it doesn't quite fit the model of Africa. And if we don't have, so Africa consumes around 25% of the world's health burden, but it's only 15% of the world's population. So if you don't sort out health security in Africa, you're going to have a problem in the rest of the world, as my good friend Victor said earlier. So what is it that we seek to tweak? And I'm not calling for a radical overhaul, but we need to listen to the people on the ground. What are they saying? There's not a shortage of financing. There's lots of financing. Everyone came up with financing models, a plethora of it. The problem here is, how do you apply that financing to create demand and shape the market? Because if you don't have demand, you can finance 50 factories on the African continent, but if not one of them is receiving demand, It's the biggest waste of financing on 50 facilities you can imagine. So we need to rectify that. So my message, they say you mustn't give too many messages, so I only want to give one message today. Okay. The message is, let's look at how we channel the financing towards sustainable, and I need to underline the word sustainable very boldly. How do we channel that funding towards sustainable demand generation so that we can fill up these facilities, we can get economies of scale? Manufacturing is all about economies of scale, so that Africa itself can be competitive. Because you also don't want to provide loans and grants to something that is going to be uncompetitive in the long term. So it can only be competitive if you have economies of scale. Now, the final point I wish to make is, there's often, I suppose, a little jaundiced view that gets taken. Can Africa really pull it off? So I want to give you the example of my company, Aspen. So Aspen today is a world leader in general anesthetics. So probably if you go to a facility and have some type of surgery, either in Latin America or in Canada or in Europe or in Asia, there's probably a 1 in 5 chance that you will be receiving an Aspen product. And that's an important vote of confidence, because you want to wake up after your anesthetic, right? So 2 concluding messages. Let's channel the funding into sustainable demand generation. And the second thing is, we need to have belief and hope that Africa can contribute to the broader health security. If we don't have global health security, we can never have global peace and security. It's been a wonderful pleasure and a privilege being here today. And I hope I kept to the board there. Am I right? Okay.
Nothing to add to these 2 very strong messages. Let's move to Maha, BNP Paribas. What is bringing a commercial bank into this One Health space?
Thank you for inviting me. Maybe I want to start, well, I need to start by saying that repeat a little bit on the fact that this topic is, of course, essential, crucial to economic and financial stability. We saw it at multiple times, though. It's all linked. So for a commercial bank, it's really important to have financial stability and economic stability. So that is why we are here. And it also links this topic, the fact that to build coalitions, to build multi-stakeholder coalition with the fact that it has a multiplier effect. So being all together enhances the outcomes. And this is something that we experimented quite a lot, and especially maybe to give you one example, because we don't have a lot of time. So it's outcome-based finance that we experimented with AFD. Because how does it work? We put all the stakeholders together. For me, the One Health is very well illustrated by this outcome-based finance. It's exactly the same logic. It's breaking silos to work all together for aligning interest for an outcomes that we all hope for. And how does it work? We have private investors that are investing in an experimental R&D, research and development program, that is programs that are based on preventive actions, and that say that when you do prevention, it's better than if you have to cure them afterwards. It's less costly and it works better for everyone. And then you have independent evaluation. So there we can have all the ones that measure the impacts, people that are used to do research and to measure the impacts on the ground, that will actually follow all the impacts that are generated on the ground. And only if positive, demonstrated scientific impacts are there, then you have public money or philanthropic money that will reimburse the investors that took the initial risk. And so it's the best model of blended finance that I have found. And we did that with AFD because we did it, it's not on a one health issue, but it's on a health issue. It's on menstrual hygiene in Ethiopia. And it showed how well it worked because we put all together unifying 3 pillars. So we break silos. It was WASH pillar, it was the health, the manufacture of protection pads, that is the second pillar. So industrial protection, manufacturing of pads for women that are reusable. So it's also environmental pads. And the third topic was about the mentalities, changing mentalities. And so the 3 pillars were put together in one program. There was an independent evaluator that came to evaluate all the progress, and it worked better than having one program on WASH, one program on manufacturers, and then one program on sensitivity. So this is a way that we can better work together between commercial, DFIs, also researchers, corporates, public development banks, and also anyone that do research. So this is a way, typically model that can be replicated on One Health issues. For example, agricultural. If we say the value chain of agriculture, it can also be to have more resilient agricultural practices and see exactly how do they impact the health of the smallholder farmers, but also on the consumers and etc. So this could be replicated. And also I'm happy to, another initiative that we have with IFAD, we co-built the Just Institute, which is also an institute with coalitions to enhance the way of working together to better finance agriculture, smallholder farmers, and to better finance the inclusive finance sector so that they develop green loans that are dedicated to change the practices of the smallholder farmers and thus also enhancing the One Health issue.
Thank you very much, Farah. And we're extremely proud of supporting this program, which is really making a real difference in the life of young women in Ethiopia. And it's also, as you said, it is a One Health project. It brings together sectors. It is science-based. It's working at the crossroad of investments in human capital and environment. Let's close this panel with the last speaker, Benoît Faraco, our France ambassador for climate negotiations, and really talk about something big, which is climate finance. And for many years, it looked like climate finance and health finance were 2 different worlds. But it's changing very rapidly, and the 2 agendas are now getting increasingly close.
No, thanks a lot, and happy to be here. Thanks to my co-panelists, because I was here since this morning listening to you, and I think it's a perfect illustration of what we want to do with One Health and this summit, and continuation also for G7, and reintegrating also all these elements and feedback in traditional environment negotiation, not only on climate, but on biodiversity. I will try to be super brief too, and everything has been said. My main message today is something missing from my perspective, and including from climate finance, is not money. In the climate field, we mobilize 100 billion per year, and we try to basically balance between adaptation and mitigation. And of course, health has to do with a lot with adaptation, but also with mitigation. For instance, working on clean cooking to reduce emission, you also improve health. So there are obvious connections, and we have resources. We committed to gather at least 300 billion per year by 2035. So it's a lot of new resources coming in this area. But the one thing is missing, and that's my message today, is planning. Planning. Why? Because climate change has a plan. He has a plan for extreme weather event. He has a plan for food security or for food insecurity. And we all know that in all all of these areas, including the fight against pandemics, the big question of water and water quality and water quantity, which are key as climate impact, but also for global health. We have the technology, we have the science, we have the knowledge, we have the institution, and we have resources. So the big question is, for me, how do we align for these resources, and how do we work together, including probably at local, domestic and regional level in more integrated planning, because as a lot of panelists said also, there are business cases for investment, for private investment. And if I give you an example of what we try to do in France regarding planning for climate change, we develop a +4-degree scenario that we send to all the actors, the local authorities, the companies, the government, the health authorities, in order to ask them to prepare the plan. And they discover, preparing this scenario, which is a worst case scenario for France, that they can mobilize private and public resources in order to boost investment in all sectors, including the major risk which has been evaluated in France is the risk for casualty from heat waves. And those demonstrations, including, for instance, country platform, gathering all the partners, all the banks with local authority, allow you to catalyze the resources and also to align with policy reform, which are critical. And I will stop there because my 3 minutes are left by saying, I started my point saying no more money is needed because we have resources. It's not totally true. You know that France is very committed also to advocate for global solidarity levy in order also to have an approach that is more fair and ask also the richest to contribute. So that's why we launched this coalition for premium flyers in order to gather some small taxes that can make a lot of difference in some countries where you need more concessional and grant-based finance. I will stop there. Sorry for keeping in between your lunch, but I think I want to thank you all in this room because you provide a lot to continue the effort. Thank you so much.
Thank you. Thank you. And certainly bringing climate finance together with global health financing is already underway, but it's going to be more and more of a collaboration. Let me conclude this panel. Very clear messages from coming out of discussion. The One Health agenda is not only about pandemic preparedness, it's about investing across human, animal, and environmental health. It's in line with the broader Healthy Planet and Healthy Lives agenda. One Health is fundamentally about public goods, global public goods, which requires collective action and sustained international financing. That's the whole agenda of new international levy to fund those global public goods. It's not only about more resources, it's about better structuring and aligning financial instruments. Everybody mentioned that. And Public Development Bank has really have a critical role to play in structuring, de-risking, crowding out private capital. And I will finish by saying that One Health will require not only financing, but a shared understanding and the call for a common platform of investments of our colleagues from Islamic Development Bank and using the platform, the financing common platform is really essential to build that common understanding and that common action. Thank you very much. Thank you to all our panelists. And we're going to move to more hands-on panels that are going to present to you some projects.
The very good news is that everybody's running late. So this is good news for us. Please, I would invite every one of you to remain seated as we are about to start the next panel. So we have, as Agnès just mentioned, we do have a need for shared understanding. But the question that is triggering every one of us is, how do we move together? How do we walk the talk? How do we walk together? And for that, I'm very honored to welcome on stage Niels Gade, Director of the One Health program at GIZ, an economist dedicated to sustainable development and global equity, former leader in international NGOs in Africa. Niels, the floor is yours. Thank you.
Thank you. I might use these mics here. Is that okay? So, thank you very much for inviting for this panel. I have the pleasure to lead you through it. It's dedicated to the question, what does it mean to invest in the One Health approach? And what I like about this question is that it frames One Health as an investment. So it's an opportunity that's waiting to be seized. And it's a tool that allows us to make better use of our resources. But what distinguishes a One Health investment from others? What makes it special? There are certainly many things. We have heard it in the first two panels, but the three things I think stand out. First, the returns of a One Health investment come in terms of better health. And that doesn't mean just better health for humans, but also better health for animals, for plants and ecosystems. That makes it harder to measure the impact of One Health investments than for commercial investments, which have a financial return. But that doesn't mean that it's less relevant. The other way around, I would argue that health is more directly related to our happiness and well-being than money. So it is relevant, and we need to dedicate our resources to it. Then the other point that has already been mentioned is that the returns of One Health come as a public good. So it's not only available to individuals, it's available to groups of people, groups of stakeholders, which creates a problem that they are tempted to take the position of a free rider. Third is, what makes it special about the One Health investment is that it involves a diverse and wide group of stakeholders. The One Health high-level expert panel defines the One Health approach as following. The One Health approach mobilizes multiple sectors, disciplines, communities, and at various levels of society to work together. So lots of people have to come together, and these are not sectors, as we ironically say many times in our models. These are organizations and individuals, and all of them have their own expectations. They are all affected by One Health interventions. Also, those who bear the cost of One Health interventions are not only the ones that pay at the beginning for them, but also that come out disadvantaged through the One Health intervention. So, if we want to speak about One Health, we even have a larger group of diversity. As I said, it also includes animals, plants, and ecosystems. There are also stakeholders in One Health interventions. Because One Health interventions are hard to measure in their return, and also because they involve such a diverse group of stakeholders, there are two fundamental challenges each One Health intervention has to meet. First is to define proxy indicators that measure the return that is expected from the investment. Collecting data to measure these indicators can be cumbersome and expensive. And also, we also have always to bear in mind whether these indicators really measure what we expect as an outcome of the intervention. And second, the second challenge is that the investment have to be based on some kind of agreement or negotiations between all the stakeholders that are involved. unavoidable trade-offs need to be managed. That requires consultations and negotiations prior to the intervention, as well as strong government structures during the intervention. All this adds to the cost of the investments and dampen their yield. So recognizing these challenges, you might ask the question, well, is it worth it? Shall we really embark on this highly ambitious One Health approach? Or is it impossible, or at least impractical, to do so? Sure, it's a given that there are costs involved in any One Health intervention, and One Health protagonists like Jakob Sinstab have reminded us for many, many years that we need to evaluate the value added that a One Health intervention can render to us. But disregarding the One Health approach would be a huge missed opportunity. There's no other way to confront AMR other than curbing resistance pathogens in humans, animals, and ecosystems at the same time. There's no alternative to preventing pandemics than protecting intact ecosystems. And we cannot provide healthy food to our and the future generations unless we respect the health of the soils in which we expect the food to grow in. These are all but a few examples of how the One Health approach can guide us to confront the triple planetary crisis that we are facing. In short, even if the cost is substantial, investing in One Health interventions can hold huge dividends. Indeed, ultimately, they may be the key to our own survival. So with this having said as a framework for the One Health approach, I now have the pleasure to invite my panelists. So let me start with Dr. Benoit Vallée. He is a distinguished physician and senior civil servant currently serving at the Cour des Comptes with a career spanning the highest level of health administration. He previously served as a French director for health and as a president of the French Agency for Food, Environmental and Occupational Health Safety, ANSES, I think that is, France's agency with a One Health mandate. Thank you, Dr. Benoit, for being with us. Second, representing the Secretary General of the Indian Ocean Commission is Ms. Juliette Janin. Ms. Juliette Janin, thank you for being with us. Ms. Janin is the Chargé of Mission in charge of education, culture, vocational training, entrepreneurship, gender, and health at the Indian Ocean Commission since November 2022. She was previously a history, geography, and geopolitics teacher in La Réunion Island. Third, it's my pleasure to welcome Dr. Prima Josephine. She is the Director of Communicable Diseases at the Ministry of Health in Indonesia. She has led national immunization vaccine programs. With her background in medicine and public health, she has played a key role in strengthening vaccine access, improving immunization coverage, and supporting digital health systems. Then moving on to Asia, representing the Asian Development Bank, we have the pleasure to have with us Rickard Elfing. Rickard is Principal Social Sector Specialist. He leads complex, multi-sectoral operation focused on human development and environmental sustainability, and he's a key architect of the Regional Flyway Initiative, a visionary program designed to protect and restore vital wetlands across the East Asian, Australasian Flyway. And then, at the end of our journey, we go to the Caribbean. We are pleased to have with us Emile Danielle Garcia. She's working for Expertise France as a senior expert leading an EU and AFD-funded program supporting the strengthening of health and social protection systems in the Dominican Republic. Good, let me
My first question goes to you, Dr. Valle. Sorry, I just have to hear. Yeah. Working at ANSES, can you tell us more about the One Health mandate of ANSES in France? What are these functions, its funding model, and why is it important to invest in such One Health institutions?
Thank you very much, Mr. Chairman. Thanks very much for this invitation. I'd like to describe a little bit ANSES, which is the French Agency for Food, Environmental and Occupational Health and Safety. It's a key One Health institution, as you mentioned. It combines research, risk assessment, and surveillance to support public policy. The agency employs around 1,400 people, including 750 researchers across 16 sites and 9 laboratories. These are in France, including overseas, at La Réunion. Its work is structured into 4 main divisions: resources, research and reference, science and expertise, and regulated products. One of ANSES' major strengths is its central role within a broader French ecosystem. The French ecosystem about this One Health organization is important, but it contributes by itself to a national hub connecting institutions across health, environment and agriculture, including public health agencies, environmental bodies, and major research institutes. It also integrates social and economical science, recognizing that One Health cannot exist without considering feasibility and societal acceptance. ANSES is also deeply embedded in European and international collaborations that I will not detail. But despite its ambition and responsibilities, ANSES operates within a relatively modest budget, I would say, around 170 million euros, which is far below the major research organizations like CNRS, INSERM, or INRAE, which exceeds 1 billion euros annually. So you can see the gap is very important. This budget is primarily allocated to human resources, 50%, operations 20%, and structural cost, including investment 30%. The research and reference division by itself accounts for 1/3 of spending, while science and expertise represent just over 20%. Importantly, only about 7 million euros per year has been dedicated to funding One Health research projects over the five past years, and despite a very strong demand and a very low selection rate. So there is more to do.
Thank you.
Governance, I will finish by that, but I think governance is a major challenge for us. Around 70% of ANSES funding comes from multiple ministries: agriculture, health, environment, and labor, but coordination between them remains fragmented. Each tends to prioritize its own return to investment, limiting the development of a truly integrated One Health strategy. The remaining 30% of funding comes from ANSES' own resources, including taxes, fees, services, and research contracts. Some additional funding exists, for example, through European programs or national research calls, but it remains fragmented, insufficient, and not coordinated, except by us, but with sometimes interministerial debates and needs for arbitrage. Overall, ANSES has strong scientific capacity and strategic positioning, but lacks the financial scale and governance integration needed to fully deliver on its One Health mission. I think we can accelerate the momentum. I think ANSES is in a strong position to do so. First, and we need some key levers for that. First, we need a clear and unified national strategy for One Health. It exists, but it's not very strong and not very well defined at the present time. Second, I think we need to rebuild the One Health financial model that is needed. Third, I think the research effort in prevention must be significantly scaled up, whether it will go through a national prevention program, France 2050, for example, or European flagship initiative dedicated to One Health prevention.
Thank you.
And at last, and I will finish by that, I think we need standardization and accountability because they are key. And for example, the development of a shared framework such as prevention standard, the SPEC AFNOR, you know, this has been proposed very recently. And I think, and you will find this on the different table. And I think that this SPEC AFNOR is a way to align stakeholders around common guidelines and measurable impact indicators. And you insisted on this aspect previously on. Thank you very much.
Yeah, thank you very much, Dr. Vallée. Yes, you can see that. We speak a lot about scarcity of resources. One resource that's very scarce, unfortunately, on this panel is time. So I have the unpleasant task to ask you to keep your contributions as short as you can. But let me now direct my question to Ms. Jana. Based on the Indian Oceans Commission experience with the SEGA One Health Network, and can you tell us why investing in regional surveillance capacities is essential, and how to ensure sustainable financing of these capabilities? And again, a short answer would be appreciated.
Okay, I will try to be short. So I will deliver 4 messages. So first I will tell you what is the SEGA One Health Network. So it's a regional network for the health security in the Indian Ocean region, structured around 7 thematics, including infectious disease, non-communicable disease, and climate, environment, health. It is led by the Indian Ocean Commission. So what is the Indian Ocean Commission? So it's a regional organization composed of Comoros, France through La Réunion, Mauritius, Madagascar, and Seychelles. So the network we have was established in 2009 and is the pioneer in the practical implementation of One Health in the region and in Africa. So for us, investing in One Health is investing on 3 essential pillars. We invest on people. We have trained more than 400 field epidemiologists, including 38 advanced, and we have just finished our master, the first master of the FATP master in the region of 16 people. So in total, we have trained more than 4,000 professionals in the regions. So this is show how humans are the most important in One Health, if you want to have One Health system that work. Second, we invest in systems, not only in crises. We have reinforced 40 laboratories, for example. We have reinforced also 40 surveillance systems, and we have structure also surveillance system that are in all our countries. So that enable all the countries to share information all together and sensible data, because we are 5 small islands and we cannot work isolated. So that enable us to prepare, respond to disease like plague, like dengue, chikungunya, or other disease together. So, and the third investment we have made is in governance. We were speaking about sovereignty of countries. So we have been funded by the French Agency of Development and the EU, but mostly we work with the countries. We work with member states. We have focal points in 3 different ministries that work all together all the time. They train together physically, so they trust each other. And because they trust each other, they share sensible data. And then it enables us, we convince then the ministers to validate, and we have the first fiduciary fund of the organization, meaning we don't have only money coming from development aid. It's the member state contributes to the health system. So this is really important for us.
And how did we manage this? It's thanks to like the partnership we have with the AFD since 2009. It's like since the beginning, it was they told us that you need to appropriate yourself the mechanism. You need to work on this to like stabilize and all this. Yet what we have been doing. And because, like my last point, because it's like we are a proximity regional organization. We are not a continental organization. We are very close to our member states, and our staff come from our member states, and we don't depend on bilateral agreements. It means when there is a crisis in a country, we can continue our work. So that's why, like, working with development bank will be my conclusion. Will enable us to work together for the global economy and for the economy of our member states. I think we are a model that can be reproduced everywhere in the world because we work closely with all the actors. So thank you.
Thank you. Thank you very much. Dr. Josephine, Indonesia's Pandemic Fund project is a strong example of a One Health approach combined with catalytic financing. We've heard about it in the previous session. So you leverage with 25 million that you've got from the Pandemic Fund, close to $250 million in co-financing. Can you tell us more about the project, and is there one key lesson that you would like to share with development banks and country representatives to better design and finance One Health interventions?
Okay, first of all, I would like to thank the committee for giving me the opportunity as a representative of the Indonesian Minister of Health to give a lesson learned One Health approach in Indonesia as a collaborative approach for pandemic resilience and preparedness monitoring. And as we know, One Health approach is a coordination across sectors in the control of zoonotic diseases and also emerging infectious diseases. And this already implemented in our country by the Indonesian government through the implementation of regulation. So we already have such of regulation. For example, we have a presidential instruction in year 2019 that mentioned increasing capacity to prevent, detect, and respond to outbreaks, pandemics, and global health emergencies. And we also have a regulation of the coordinating minister for human development and culture, number 7, 2022, concerning guidelines for the prevention and control of zoonosis and new infectious disease. This regulation requires also the establishment of a commitment, a committee, the establishment of committees at the national and also at the regional levels. And for the One Health Committee, now is still drafting the One Health presidential decree in Indonesia. And we also have a Minister of Home Affairs Regulation 2018 mentioned the standard technical guideline for basic services in the regional disaster, and also for including the non-natural disasters and zoonotic outbreaks for One Health, and also Minister of Home Affairs circular letter at 2023 for handling and control of zoonosis and EIDs in regions related to the formation of regional coordination teams. We call it TICORDA. So all of them require capacity and strategy for One Health implementation of the One Health approach in the prevention and control of zoonotic diseases and emerging infectious diseases in Indonesia. So in terms of the One Health approach in collaboration with various partners, we already have application called SICE that has been developed as signal sharing between human, animal, and wildlife sectors. This will enhance our detection capacity as well for the potential zoonosis diseases, as we know that almost 70% of the emerging disease will be zoonosis. So Indonesia have a best practice for a collaborative approach for pandemic resilience and pandemic preparedness. We call it CARE-I. supporting by the pandemic fund grant that you already mentioned. So the key benefit for Indonesia from leveraging the pandemic fund through the CARE project are first is in terms of health security. CARE strengthens Indonesia's capacity in surveillance, early detection, and rapid response to emerging infectious diseases. It also promotes an integrated One Health approach, connecting human, animal, and environmental health systems to better manage pandemic risks. Second, from a financial perspective, the project provides grant-based funding, which means it does not add to the country's debt burden. At the same time, it offers a high return on investment by focusing on prevention, which is significantly more cost-effective than responding to large-scale outbreak. For third, CARE contributes to system and capacity building by improving laboratory infrastructure, strengthening the health workforce, and advancing digital health systems. It also enhances preparedness and response capacity at the subnational level. And fourth, the project supports global leadership and partnerships, elevating Indonesia's role in global health diplomacy and providing opportunities to showcase national progress in international platforms such as the One Health Summit. Finally, CARE ensures a sustainable impact by embedding long-term resilience within the national health systems. It aligns with Indonesia's health transformation agenda and strengthens the country's readiness for future pandemics.
Thank you very much, Dr. Josephine. Wonderful. Thank you. Our time continues to run fast, but we want to hear about the Regional Flyway Initiative. Ricard Elfing, you were part of designing it, but it wasn't initially designed as a One Health project, yet it addresses simultaneously biodiversity loss, food security, climate resilience across multiple countries. Would you say that this initiative, in fact, could be considered as a very relevant example of One Health investment for ADB's portfolio, both in its intent and its implementation?
All right, so in light of our own food security, I promise to keep the timeline. I am not the chief architect of the project, but I'm representing ADB in presenting it. So Asian Development Bank is basically a bank based out of Manila, Philippines, and we cover Central, East, Southeast, South Asia, and the Pacific. And we work in Indonesia. We have one of our biggest co-financed partners and projects in Indonesia, which I think is with the Islamic Development Bank, with the World Bank and AIIB. So working together among banks is definitely possible once you have identified the key challenge that you want to pool around. So thank you for presenting this initiative, by the way. I'd like to mention two things. I'd like to mention this Regional Flyway Initiative, but before I do that, I'd like to make a call also on how we work in fragile and conflict countries. I am personally very much involved in developing health projects in both Myanmar and Afghanistan. Both these two countries are currently facing a massive influx of and movement of people. Both Myanmar and Afghanistan have an exodus on one hand from Myanmar, around 4 million people to its neighboring countries. Meanwhile, Afghanistan has an influx of around 4 million people coming in from Iran and Pakistan. And as we know, diseases do not recognize borders. And in this case, we see the complexities in terms of supply chain of medicines happening. We see a health workforce that is not necessarily able to deliver the services. And we see also people living closely to livestock and weak veterinary services. Basically, a collapse of an already weakened system that threatens health security in those regions. And I'm saying both these two countries have around 7 neighbors. So I'm flagging, and that is a regional approach. It's a regional public good, and it's a need for addressing regional health security. The Regional Flyway Initiative is an ADB-supported initiative, and the vision of this initiative is to mobilize around 3 billion in investments for wetland protection and sustainable management. The East Asian Australian Flyway encompasses of 22 countries from the Arctic Circle to Australia and New Zealand. Over 50 million migratory water birds and many other animal and plant species rely on the flyways, thousands of wetlands for food and shelter and other needs. The ecosystems support nearly 100 million people in East, Central and Southeast Asia and the Pacific by providing flood regulation, food, recreation, tourism and jobs. The key strategy is to develop a pipeline of loan investments at key sites mainly protected by the areas, collaborate with line ministries, various type of local partners, communities, private sector and the academia. The aim is basically to support multilateral and bilateral financing through loans and grants up to 50 to 100 projects, using technical assistance for helping to prepare these investments. The initiative offers a unique opportunity to demonstrate One Health action in action. Firstly, it uses ecosystem assessments to inform investments on One Health. This helps to demonstrate its fundamental benefits and showcase its monetary value. Secondly, it supports the interaction between the natural world and local communities. This lays the groundwork for One Health actions. Thirdly, wetlands provide essential ecosystem services to support human health. They supply clean water, regulate water levels, and support biodiversity. Lastly, it illustrates the overarching ecosystem approach. This approach integrates environments from the beginning and provides a mechanism to leverage core financing. Now, lastly, what is the key takeaway message here? Yeah, as you mentioned in the beginning, Niels, the RFI initiative is already implementing One Health activities, but we are not necessarily capturing as One Health. So the point I'm trying to make here is that it will be critical for developing tools that are helping us at design when we are presenting new projects so we can capture these important One Health initiatives. At the moment, there are AI tools out there that can go back and see on projects that have been approved and are currently being implemented. But more importantly, going forward, if we want to scale up One Health actions, is to capture that at the design stage. And developing these key tools will be critical, and this is how we can join forces with other development banks and maximize the outputs for One Health. Thank you.
Thank you very much. Thank you, Richard. And now to you, Ms. Garcia. Your project relies on blended funding approach, combining budget support, technical cooperation, investment, and policy dialogue. Can you tell us more about its financial structuration?
Yes, thank you. And if I may, I will switch in French. Je vais essayer d'être assez brève, mais pas trop rapide, ce qui est parfois l'enjeu, de ne pas accélérer le rythme. Donc je vais vous parler de la République dominicaine, qui est un bon exemple justement de pays qui a décidé d'investir à la fois dans ses systèmes de santé, mais aussi dans ses systèmes sociaux, c'est-à-dire en faveur des politiques sociales pour les rendre plus adaptatives. Et cela grâce justement à un programme de financement mixte, un blending qui a été évoqué auparavant. Donc en quelques minutes, ce que je voudrais ce sur quoi je voudrais insister, c'est l'importance justement de la structuration des financements lorsque l'on intervient en faveur d'approches comme une seule santé, One Health, et les protections sociales adaptatives, qui sont des approches qui requièrent des très grands niveaux d'intégration, et ça a été dit et redit. Mais comment y parvenir lorsque les systèmes eux-mêmes sont déjà sont assez fragiles? Et donc la priorité de la République dominicaine, ça a été une prise de conscience lors de la Covid, tout d'abord se concentrer sur le système de laboratoire, la santé, qui souffrait de lourdes défaillances, et également de se doter d'un cadre stratégique pour structurer les actions sociales. Donc ces deux axes sont les deux axes principaux de ce projet. Et donc, je mentionnais l'importance du blending, car l'AFD, donc, qui a apporté un financement à la République dominicaine donc, lors de la pandémie, pour étendre les programmes de protection sociale, a permis de lever donc, une subvention financée par l'Union européenne, qui a un mécanisme justement qui finance de l'assistance technique lorsqu'elle est adossée à un prêt de politique publique. Et dans ce cas de figure, cela fonctionne plutôt bien, puisque la coopération technique qui est mise en œuvre donc, par Expertise France permet justement d'alimenter un dialogue de politique publique en parallèle et en complémentarité des investissements qui sont réalisés souvent à travers le prêt. Et donc ce dialogue de politique publique, sans trop m'étendre, mais a permis sur la durée, justement sur 4 ans, d'obtenir à la République dominicaine de se doter d'instruments de politique publique, donc, qui ont été permis par l'accompagnement technique, le dialogue avec les différentes directions, à la fois de la santé, mais aussi des ministères de l'Agriculture et de l'Environnement, se doter de stratégie One Health et de plans. Cela a été dit tout à l'heure, je pense que l'importance de la planification, les financements sont importants, mais la planification, cette capacité à planifier des États est clé, notamment au moment de vouloir interagir avec d'autres ministères et ne pas fonctionner en silo. Mais cette capacité, je pense, de planification, elle est aussi possible si les financements eux-mêmes sont davantage structurés, et cela a été dit auparavant et vient d'être répété, l'importance de la coordination, et là je termine, c'est l'idée principale, mais l'importance de la coordination entre les projets et les différents financements des banques de développement est clé, puisque chacune justement porte des projets qui ont une vision holistique et donc interviennent sur plein d'aspects. Et s'il n'y a pas cette coordination qui est possible justement avec ce dialogue très étroit avec les ministères, eh bien on risque d'altérer l'efficacité de nos interventions. Merci.
Merci beaucoup. Merci beaucoup, Madame Garcia. And thank you to all your panelists. I think you brought up very illustrative examples of One Health. I think we see how difficult it is, but also how worthwhile it is. Thank you very much, and sorry for overstepping our time a bit. With that, I hand it over back to Isabel. Thanks a lot.
Thank you. But as you know, the closing session with the two ministers will be in 7 minutes. So in 7 minutes, you will have amazing panelists to close. So just before, I would like to ask to come on stage, please, Dr. Tamer Rabi, Global Program Lead for Climate and Health at the World Bank. Thank you so much for your words before our ministers come in. Please take a seat so we can finalize the session. Thank you so much.
So I won't have a panel. Okay, so I'll speak from here.
Okay, 5 more minutes. No, 20 minutes. Okay, so 10. Here we are.
Okay, so first of all, thank you so much for the kind invitation to join you today, and to have the pleasure also of welcoming two distinguished panelists. I'll call upon them now. So if I could have Mr. Marc Leondre from the AFD and Ms. Francesca Colombo from OECD. I just wanted to start off at the beginning by saying that this summit has certainly made a very compelling case across multiple angles, multiple sectors, for why One Health is really critical and matters. In fact, we have clearly and consistently heard that when it comes to One Health, this is not a separate conversation in relation to human, animal, or planetary health. This is a single conversation. We've heard that there is a role for public development banks in this space and that there needs to be a shared common understanding of where to go. We've also listened to what our clients are saying. In fact, the Honorable Minister from Nigeria made the point very clear that there are very important strategic shifts that need to be made. We need to be moving more towards predictable financing. We need to be moving more towards integrated systems. And it's against this backdrop that this particular session comes really to sort of build on this foundation and put forward a key question, which is both strategic and technical. How do we work together as public development banks to ensure that we have a tagging system for One Health that allows us to do the level of understanding needed for financial flows going into this space and maximizing investments in that regard, while also at the same time understanding the levers for a common approach. With that, I'm actually going to ask my panelists to provide their comments and reflections on how do we go about really putting together this tagging mechanism. Mark, I'll start with you. I'd like to ask that you walk us through some of the methodological considerations for tagging exercises. Over to you.
Thank you very much, Tamer. Thank you for putting up the slide. So just to be very brief in the interest of time, as I just wanted to display a very interesting methodological specificity around One Health tagging, because we've heard yesterday and today that One Health is not a sector, it's the strategy, a strategy to reduce systemic risk. And in order to implement a One Health tag that could be commonly applied among development banks and institutions, thus providing internal and external visibility, we need to take into account the specificities linked to the fact that One Health is a strategy. Among them, just two very brief questions. First, Professor Morand insisted in his speech on primary prevention. How do we account for primary prevention when we know that, for example, reducing deforestation brings benefits in terms of One Health, zoonotic spillover reduction, but it's usually accounted for as a climate or as a biodiversity investment. So that's a very interesting challenge. Also, what do we do with the, how do we verify the intent? Niels was mentioning that in One Health projects, you need an intent for an intersectoral approach. And how do we verify that the projects actually come within this, this approach? So those are examples of the questions we can ask ourselves when we try to design together a tag that will gain in terms of visibility if we could harmonize it. There are already promising methodologies that have been put together by World Bank, by GIZ, and those are very good starting points if we want to go on with this challenge. In terms of external accountability, maybe this tag could also be an interesting approach to work together with the tracking projects, for example, the PPR tracking. So I think it could be very interesting to hear Francesca's take on this.
Okay, move on. I'll have three messages, but obviously the first thing to start with is that if we want to get the financing right, we need to get the architecture right. And by architecture right, we also mean the data architecture, the tracking, the accountability framework, and the transparency that goes with that. So I have three main points that I wanted to make. The first one is, why do we need to have that transparency? And quite clearly, it has been mentioned very much today that we live in a context of very tight financing. In terms of global financing, the multilateral development financing reports last year warned that ODA funding for public goods and for global development finance has been dropping by 15%, and we're going to be releasing new data just at the end of April in the context of the G7 development ministerial, which shows a further reduction by 23 to 30%. So we are going to have less money and fewer actually donors which are contributing to development banks financing. Now in this context, there are risks to be managed, and that's where a marker or a tracker helps us to understand whether we are on track. And the risks is to avoid that by channeling financing to important global public goods, such as One Health or even pandemic preparedness and response, we are not compromising concessional financing and other financing for the most vulnerable people and the most vulnerable countries. So we need to make sure that we get those objectives, which are equally important, right, through a tracking and a tagging system that allows us to that transparency and in managing possible trade-off, avoiding shifting really funding from one objective to the other. The second issue is obviously in doing a tracker or a tagging is really to have more transparency in terms of financing across different sectors, and that's the One Health issues. And it's also the case for pandemic preparedness and response tracking. We need to create an agile system that allows us to understanding what's the level of the financing of resources without creating new accounting structures, because we do have already accounting structures. And at the OECD, we have two which are particularly prominent and important: the system of health accounts and the creditory reporting system. So we don't want to create a new accounting framework, but we want to use what we already have to tag what's the financing on specific projects that are relevant for One Health. And so, for example, in the system of health accounts, there is one category that looks at multi-sectorial approach and health promotion for multi-sectorial approach, which includes things such as sanitation, food safety, and zoonosis. Very few countries report on that. We can encourage countries to report more and use that as a way of tagging how much is spent towards One Health. Similarly, in the creditory reporting system, you can use artificial intelligence tools and machine learning to do search for keywords and understand how much of different projects from development finance are devoted to One Health. And this has been an approach that actually has been used by OECD even 20 years ago by DAC, in the DAC statistics, so Development Assistant Cooperation Statistics, to having markers on spending towards the Rio goals and the Rio markers. So again, by tagging projects that relate to things like diversification or climate or also biodiversities, it was possible to understand how much was the spending towards those objectives towards Rio. So really having a tracking towards those. And that's a little bit the same approach. I mean, it will be quite important to make sure that we work together I did mention that we're working on a pandemic preparedness and response tracking. There are things which, in the way that contribute both to a pandemic preparedness and response tracker and One Health marker. What is important in all this exercise is to make sure that what we do is serving a policy objective and purpose. So any, if you want, accounting mechanism, any tracker, any marker needs to be directly related to the policy objectives. Thank you.
Thank you so much. Brilliant panel, very productive and very efficient messages. I have less than a minute to, actually a little bit over a minute, just to provide some very sort of key messages on what we have gained out of today's discussion. And I want to start off with the first message, that we're not starting from scratch. And I think it's extremely important that we emphasize that the work that we've been doing on One Health has actually been going for quite some time. In fact, The GIZ and the World Bank have operational models that have looked into tagging of One Health operations, and with very solid results. And in fact, these could form the building blocks of a very, important common framework, if you will, for One Health tagging. The second point that I would like to bring forward is that a commoner approach is going to require a consistent definition that is applied to One Health projects across all sectors. Now, of course, with that definition and at the institutional level, we could make sure that we are providing the institutional context and the guidance that would go with that. Very quickly, collective intelligence and shared methodology is going to be critical. Now, many of us are moving towards being knowledge banks, and it is precisely that mandates us to be moving forward with a common methodology, with a common approach, and to bring in that collective intelligence. And I want to also use this opportunity to say that we need to activate what already exists. Alignment, harmonization is in reach through the Coalition of Social Investments and the Development Bank's Climate and Health Finance Working Group, for which we're actually establishing a subgroup specifically focusing on One Health tagging. And my final point is to let everybody know that this is a time for action. We need to move beyond just the words. We need to put a roadmap for action on One Health and One Health tagging. And with that, I'd actually want to be able to let everybody know that there's going to be a working session later this afternoon to kickstart this process with development banks and other partners. Conversation does not stop here. Thanks so much.
Thank you so much to our dear panelists. And now it's the time to encourage everyone to join for the closing words. And it's my great honor to welcome His Excellency, Honorable Minister Budi Gunadi Sadikin, Minister of Health in the Republic of Indonesia. As we just discussed, how do we move from strategy to practice? And he leads, since 2020, the country health transformation and a key inspiration to all of us. Please join me in welcoming His Excellency.
Actually, it's not well scheduled to close this meeting, but last night we had a very long dinner and discussion with leaders in the development banks. And since I was one of the health ministers with financial backgrounds, and when I joined, I can secure close to $10 billion financing within the last 4 years. So many health ministers have problems when they are discussing about, hey, the money is not there, the ODA is reduced. But Indonesia is in a pretty well positioned financially. So I just want to give you a perspective. Yes, the ODA is declining, but sometimes we haven't really calculated how much is declining. In the last health meetings in Berlin, somebody presented to health ministers that the overall ODA reduced at the peak at 223 billion US in 2023 and went down by 60 billion to 2025. So it became 160 billion-ish in 2025. Yes, that's just quite a big amount of money. But if we look 10 years backward, the 160 billion ODA is roughly the same with 2019 ODA level. So if we have to be honest to ourselves, yes, of course, the ODA increased drastically because of COVID, but because pre-COVID numbers, and 2030 numbers is basically the same. So many bankers will ask questions of efficiency and productivity, because yes, we need a lot of ODA during COVID. And the same thing happens in health. This is the overall ODA. The healthcare ODA reduced by 20 to 30 billion from the peak. And again, the numbers is quite rather similar or slightly below 2019, but it's not that big. And the gap of 20 to 30 billion for a financial person like me, I'm sorry to introduce, I have zero healthcare background. I'm a nuclear physicist by training. I worked 30 years in banking. I used to be the CEO of the largest bank in the country. For God knows why the president appointed me in 2022 to become the health minister, and become the first health minister in Indonesia without medical background. So, but he said you're a pretty good match with this job, because you're very demanding. You have to execute very fast. You have to look for money, vaccine, etc. So now I'm trapped here. And to be honest, the pay in banking is much better than pay in health. But what I would like to share with you, I raised 10 billion US in the last 5 years. So if somebody said, Budi, we lost 30 billion, from somebody coming from finance, it's not a big amount of money. So I talked to Tedros. WHO lost, what, 4 or 5 billion from the US? I mean, this is not a big amount of money. I remember I helped Peter San raise for a global fund, because Peter San and me is a close friend in banking community, and Indonesia has a board member in Global Fund. I sit also the board member of Gavi. So we raise 10 billion, 13 billion, 14 billion every 3 years. So if WHO now has problem in looking for 5 billion, 6 billion, even Global Fund raised 13 billion, 14 billion. Gavi raised 9 billion, 10 billion. As a banker, I raised trillions of US dollar money during my career. So the money is there. The money is there. The problem that I see is many health ministers don't know how to access the money. They cannot talk to the Ministry of Finance. They cannot talk to the development banks. To be honest, the last round of financing that they received of syndication of development bank, World Bank, AIB, ADB, SDB, less than 3 months I get the approval. Yes, being a friend, personal friend of Ajay Banga for the last 10 years in banking community, competing with him helps, but still it can be done. Still it can be done. So that is the first problem. Many health ministers cannot translate and explain their health investment to the finance ministers and to the development banks. So this is the first thing that you can do. You help the healthcare ministers to create a healthcare financing pathways for the country. Hey, this is my plan in the next 5 years. This is the investment that I need in the 5 years. By the way, this is the impact, the return. How can I bring back to the economy, to the jobs, to the GDP growth and job growth, which is very sensitive for development banks. If you cannot explain, even your Minister of Finance will not approve. But if you can explain, hey, if I extend, my healthy population or reduce the death of cancer by 100,000, then the productivity of people will increase like this much, GDP growth will increase like this much, and jobs growth will increase by this much. And your finance minister will understand and support you. And if your finance minister can support you, then definitely the development banks can support you. So my first request is, please, the development banks, you reach out to the health ministers and try to explain to them how to create a good proposal, basically. And depends on their own strategy. Some country, like I said, I can borrow easily 4 billion, 5 billion, 6 billion. It's already 7 billion, 8 billion. It will be another 1 billion next year. But other countries said, Budi, yes, our country is not like you. Our balance sheet structure and health is not like your country balance sheet structure and health. Then, you as the development bank can offer them some innovative products. With Peter San, I did a debt swap. So there is a bilateral loan, existing loan between Germany and Indonesia. And Peter said, Germany doesn't want to increase the number of contributions, but let's find another, innovative way of financing. We swap your debt into the contribution to Global Fund. So the Ministry of Finance still paying money, but instead of paying money to the German government, you're paying money to Global Fund, and money is going channeled back to use to healthcare investment. That is pretty good. So it doesn't increase the lending limit of your country, but converting, the existing loan into healthcare investment facility. Of course, you have to do it through Gavi or Global Fund, because maybe Germany trusts these two institutions. But you can replicate this model to other things, where countries don't have the capacity of borrowing as other countries. But a lot of instruments, the bankers are very innovative. They can do a lot of things. So that is one thing. Help the health ministers creating the financial healthcare pathways. So they can speak to the Ministry of Finance, they can speak to the developed banks to get it done. And by the way, I mentioned it also to Tedros and try to mix Tedros with Ajay. And now they're getting along together very, very well. Last December, we had a meeting in Japan. Hopefully, we have more meeting. So World Bank now is very committed. By the way, I received 4 billion World Bank. Ajay Bangga mentioned, Budi, this is the largest ever World Bank healthcare loan in a single project, single country. I said, I'm very proud, but I'm very sad. Because why? As an Indonesian, I know, as a banker, World Bank gave billions of US dollars to build the health infrastructure, the seaport, the toll road, energy infrastructure. Why in the human infrastructure or health infrastructure is so slow? I'm very curious to see the outstanding loan of ADB, ISDB, World Bank, or AIB, and see how big is the exposure to global healthcare sector. If it is above 1% or 2%, you can increase it to 10% and 20%. Usually there is a limit of sectoral limit in any banks. So this is something that we need to do. Second, after you be able to explain to health ministers to create the plan, and one of the jobs that the development banks can do, you can create the connections. You can create the connections with the source of fund. And sometimes, why the banks is good in doing it? Because they can leverage. They can leverage the money. So like example, I remember, work with World Bank, said, I need 4 billion, Budi, we cannot support 4 billion. Then we use other banks, multilateral, to join, like the syndication banks. Second, because the interest rate is too expensive, we structure in a way, we link also with the donors. The donors can do the interest rate subsidy and also lengthen, the payment terms. So for the next 5 years, we don't have to pay. I give you one example. We would like to financing the HPV vaccination programs. Indonesia is very late introducing HPV vaccine. In 2022, we just launched. The death of Indonesian women every year is going like this because of cervical cancer, where other countries are going down like this, because we are late in introducing the vaccine. Every year, this ranked number 2 after the breast cancer death, which is 22,000 a year. So we create a plan to do a full vaccination program of Indonesian women. It takes 15 years. I said, 15 years. You multiply by 20,000, 300,000 Indonesian women will die unnecessarily. So I said, can we do it faster? Well, the best is Australia, Malaysia, they only do it in 10 years. Let's do it in 5 years. But we don't have the money. We don't have the money to buy the vaccine, HPV DNA testing, the thermal ablation, etc. I said, this is my expertise. So let's borrow the money. Need 4 billion, 5 billion. Very difficult to justify. Then we go to the philanthropy agency, and then we can get, 500 million to 750 million. And then use this to leverage, become the catalyst for the World Bank financing. Because if you can reduce it in 5 years, you save 10 years of Indonesian women's death. So the banks can bring tomorrow's today. The banks can bring the future today. So instead of waiting for the national budget to successfully fund the vaccination program 15 years, we can accelerate. We start with the 10 to 11 years old. 1 year after that, we start to catch-up program to 15 and 16. 1 year after that, we do a catch-up program, women 20 to 21, and now we are doing the boys. And with the new vaccine regime, which is not only 3, but you can only do it in once, that helps a lot. So we accelerate the vaccinations to all Indonesian women. So I wish in the next 5 years, all Indonesian women in Indonesia will live. And they will pray for me so I can go to heaven. By the way, that is the second thing. You need to, after you teach the health ministers to write a good proposal, then you need to link them with the source of funding, The last thing that I need the development banks to help. Health ministers are good in curing sick people, but not good in managing money. I can tell you. As a banker, when I give money to the customers, I know exactly which customer can repay 100% on time, which customer will repay 100% but delay by 5 years, which customer will ask for a discount 50% after 3 years, which customer will not pay forever. That is a bankers, we live like that. So we have to make sure and help these health ministers. They are all good people, but they don't understand how to manage money. So then you need to help them discipline in making money. What I can share with you as a banker, this is the most intransparent industry. The information is very asymmetric. You go to the US, the average life is 79 years old. They spend 11,900 per capita per person per year to reach 79 years old. If I were American, when I reach 70, I will migrate to Cuba and Panama. For a pure financial reason, because Cuba and Panama, you live average life 79 years old, but your cost per annum per capita is only 1,900. So you save 10,000 US every year. Rather than you spend to the hospital, pharmaceutical, to the doctors, you can spend it, buy a ticket, hotel, and go to Bali every year. If they say it's not a fair comparison, you compare to Japan. 84 years average life, 5,500. South Korea, 84 average life, 4,500. The best in my region, Singapore, 84 years average life, 3,300 US. Can you imagine why the price difference is so big? Because the information is intransparent. I just tried to do ChatGPT. If you want to do appendicitis in the United States, you have to pay the hospital, the doctors, all in treatment, 12,000 US. You go to Japan, you pay 5,000 US. Do you think the Japanese doctor is less expert than the American doctor to do appendicitis? Why the price difference is not in percentage like banking, it's in terms of multiples like in startup companies. The price difference is not 100%, not 50%, 40%, it's 3 times, 4 times. The cost of drugs, Crestor, in Indonesia is like 500, in Malaysia is 100. How come the price of pharmaceutical can be 3 times, 4 times? I think I heard Donald Trump also complaining that the US pay the most expensive drugs, subsidizing by other countries. Yeah, that is what I heard. I don't know whether it's true or not, but I know it's very expensive. In United States. So this is an industry where you need more banking analysts, health analysts to compare, the cost of treatment in every country. In banking, you cannot do that. You want to buy a 6-year treasury, 5-year treasury bond in US, in Indonesia, or in Russia. If the price difference is more than 5%, everybody will arbitrage. Here in healthcare sector, happening everywhere with the multi-price. So the discipline in pricing and execution, the development bank can help the healthcare. So let's to summarize. Number 1, please teach the healthcare, the health ministers how to create a financial pathway for individual country. So they own it also. They own it. Number 2, what you need to do is link them, these health ministers, to the source of fund and help them with innovative financing tools. So it's with each country requirement. Some country has a better balance sheet, some country has a very bad balance sheet. And number 3, help them to be disciplined in spending, transparency, comparison. It is something that in finance is every day we are doing it, but we need to replicate this into the healthcare sector. By my last advice, I don't know how many people coming from health and finance in this room. This is what I feel. As a banker for 30 years, I raised trillions of US dollars for my client. It's so much money, but I feel so little contribution to humanity. I also receive a very big salary. I moved to Minister of Health, receive a very small salary compared to CEO of the largest bank in the country. I raised even only 10 billion US in the last 5 years. Very small amount of money, but I tell you this, you feel so good because you feel so much contribution you have done to humanity. So my advice to all of you financial person in this room, remember this, the best wealth is health. And consider to follow my path to move from finance to health. Thank you.
Such an honor. I think that everyone will move into the One Health, for sure. Now it's my great honor and pleasure to welcome our keynote speaker to close our event this morning, His Excellency Dr. Mustafa Ferjani, Honorable Minister of Health of Tunisia. Please, the floor is yours.
Merci beaucoup. Merci à la France d'organiser ce sommet mondial One Health qui intéresse les êtres humains du monde entier et de m'avoir invité à clôturer cette session. Donc, Excellences, Messieurs les ministres, Mesdames et Messieurs, chers partenaires, chers collègues, permettez-moi tout d'abord d'adresser mes sincères remerciements à l'ensemble des intervenants pour la qualité et leur contribution à la richesse des échanges que vous avez eus aujourd'hui. Et au terme de ces discussions, une conclusion s'impose avec clarté. L'approche One Health n'est plus une option conceptuelle. Elle constitue désormais une nécessité opérationnelle, doit passer à l'action, surtout au financement. Pour répondre aux besoins des populations qui vivent presque au quotidien les désordres du climat, du réchauffement climatique sur la santé. Ensemble, nous avons souligné que les crises auxquelles nous sommes confrontés, sanitaires, climatiques, environnementales et sociales, ne sont pas distinctes. Elles sont les manifestations d'un déséquilibre profond entre nos systèmes de production, nos modèles de développement et les équilibres du vivant. Dans ce contexte, One Health nous offre une boussole. Mais une boussole ne suffit pas. Nous devons également changer d'échelle, de méthode et de moyens. 3 messages clés se dégagent de nos échanges. Premièrement, investir dans One Health est un choix rationnel. C'est faire le choix de la prévention plutôt que de la réaction. C'est un choix d'efficacité économique face à l'augmentation des coûts des crises. Et c'est un choix de souveraineté permettant à chaque pays de bâtir des systèmes résilients adaptés à ses propres réalités. Deuxièmement, nous devons transformer en profondeur nos architectures de financement. Les constats sont connus, les besoins sont considérables, tandis que les financements restent fragmentés, cloisonnés et trop souvent orientés vers la réponse aux crises plutôt que vers leur prévention, ce qui coûte très cher. Et de façon générale, ça a été démontré qu'un dollar dépensé dans la prévention fait gagner 10 dollars. Cela appelle un véritable changement de paradigme. Mieux aligner les financements entre les secteurs, renforcer la cohérence des interventions à partir des stratégies nationales et mobiliser les instruments innovants tout en préservant l'intérêt général de la souveraineté des pays sur leurs ressources et sur les choix d'investissement. Troisièmement, les banques publiques de développement, tant nationales que multinationales et bilatérales, ont un rôle déterminant à jouer. Par leur capacité d'investissement, leur ancrage dans les politiques publiques et leur effet de levier, elles sont au cœur de la transition vers des modèles plus intégrés et durables. Mais pour pleinement assumer ce rôle, elles doivent encore renforcer leur coordination, en particulier entre les institutions de financement nationales et internationales, partager leurs outils et intégrer pleinement le principe One Health dans le cadre opérationnel. Donc, on doit passer de la théorie, de la parole, des écrits, vers l'action, et l'action nécessite financement. Donc, la question n'est plus de savoir s'il faut agir, mais comment accélérer collectivement. Et c'est précisément l'objet des pistes évoquées aujourd'hui. Mieux structurer les financements concessionnels et être plus innovants dans nos instruments financiers, mobiliser tous les acteurs de financement, dont le réseau philanthropique, et construire une coalition d'acteurs capables de produire un impact durable. En somme, pardon d'insister sur ce point, la réussite de One Health repose sur une condition fondamentale, la cohérence. Cohérence des politiques publiques, cohérence des flux de financement, cohérence des échelles du niveau local au niveau global. Et dans cet esprit, je tiens également à saluer la déclaration conjointe des banques publiques de développement en tant que responsables politiques nationales, souvent confrontées à la fragmentation des financements de l'agenda sanitaire mondial. Je crois qu'elle peut constituer une avancée importante vers une mobilisation collective en faveur de One Health. Cette déclaration tournée vers l'action autour de 3 variables concrètes seront portées au segment de haut niveau cet après-midi. Premièrement, l'élaboration d'une méthodologie harmonieuse de traçabilité des financements One Health visant à progresser vers un cadre commun. Deuxièmement, le renforcement de la coordination entre les banques publiques de développement, notamment à travers des initiatives existantes telles que Finance in Common, la coalition des banques publiques de développement, afin de structurer un effort plus aligné et collectif au service d'un agenda One Health partagé. Et troisièmement, le déploiement d'une assistance technique et la production de connaissances au niveau des pays afin de renforcer les bases factuelles, d'accompagner les acteurs publics et privés et de permettre une intégration progressive de One Health dans les systèmes et les politiques. Ces avancées constituent un socle essentiel pour passer d'engagement partagé à une transformation réelle de nos pratiques et de nos investissements. Il nous appartient désormais de traduire cet alignement croissant en actions concrètes, en investissements durables et en résultats tangibles. C'est essentiel pour les citoyennes et les citoyens dont nous sommes comptables et également pour les générations futures. Et je vous remercie pour votre attention.
Thank you so much, dear excellencies, dear distinguished guests. It's my great honor to say thank you. Thank you also to the French Development Agency for welcoming and for hosting us, in particular to Agnès Souka. Thank you so much. It's a great honor. And just one thought. I believe that we do have the tools, we do have the capital. I believe that One Health approach requires more than well-designed mechanism and financing. I believe it requires courage. The courage to take the right decision in challenging times, and the courage to break silos, to lean in and to act together. Because One Health is not a technical challenge, no. It's a leadership challenge. And if not now, then when? And if not us, then who? And remember, courage is contagious. Thank you so much.